Yeah, so I think we will start with the case. And before he's starting out, I'm going to take very brief thing. I think we have around 2, 3 couple of people. So on the right, do we have a pointer here so that we can show something? Yeah, pointer hai kya?
हाँ पॉइंटर रहेगा तो अच्छा है.
So, something basic about the echo, there is something called FPS, frames per second, on the top right. Right? You can see? Pointer, आप मुझे दे दो pointer. So I'm going to tell something to the couple of people who are here. So this is an echo image, and it is very important for us to understand what we are doing in the field. So, those who are here, you are doing regularly echo. Very good. You are doing sir echo. Very good. So you are going to present. I think Dr. Anindya is going to talk something about chamber quantification.
That's actually, our first topic is actually the chamber quantification. So before going into the patient fast, for the chamber quantification, there is a definite guidelines is given from the 2015 guidelines in the ASC, where you can quantify the left ventricle and the left atrium, right ventricle, right atrium, aorta, and everything is defined now. How do we assess the LV function? Qualitative assessment. Usually we do it. It is quite fair, but it's not fairly objective. But what is needed is that linear measurement is now absolutely obsolete. It should not be done only for the determination of the EF. You can do it to give in the linear measurement of LV internal diameters, interventricular septal diameters, posterior wall diameters, that you can do, but not for the measurement of linear measurements are not for EF. So LV dimensions you can do it, and everything is written in the books that you can do it, and these are the current slides, and you can take it. Now, regarding the volumetric measurement from the LV linear dimensions is now absolutely out of fashion. You should not do it nowadays. We do the volumetric measurement by the biplane disc summation. So now we will demonstrate how to do the biplane disc summation. Sulogna, can you demonstrate the biplane disc summation by the Santanu, you want to tell anything?
Okay, I think the image is on the right side.
Yeah.
Okay. So switch it. Can we swap it? Yeah, I think. Because
These PowerPoint can be given these. Switch it.
yeah, that's better.
Oh, okay. Oh, no problem. So this is the way you want it?
Right, I think that's
fine. You can tell simultaneously.
Yeah, can you just have a very brief 2-sentence history of the patient so that we can
check.
Nitin, you can open the mask, otherwise.
Okay, sorry. Can you just know something about the patient? Just okay, fine. Doesn't matter. Now, I think the ECG lead, I think slightly is going up, down. Yeah, can you just have the ECG lead? Yeah.
ECG is not coming properly.
I think get an image first, and there are a few things. Just get out of this and get an image. Right. So there are a couple of things I was mentioning. It's very important on the right side. If you see, there is something called frames per second, FPS. Now, the recommendations have shown that our frame should be around 50 to 70. Now, what is frames per second? It is just like a megapixel of your mobile camera. So it identifies you to to have a better picture. If you have frames less than 50 or more than 90, then you will not be analyze something called an advanced imaging, which is echo. Right? Now, this is a fairly good picture.
Yeah. Correct. So when we are doing an LV quantification, let that entire sector be filled by LV, okay, and RV, okay, so that atria will cut off. Now, because we have got only this amount of real estate with us, so let us use all those pixels to focus onto the LV. So zoom it for the LV first, and we can cut down further so that the we don't want atria currently. Let the mitral annulus come down. Further, you can reduce, yeah, reduce the depth further.
Further.
Yes, perfect, yeah. And as we see here, the two-chamber view, we are now this is, luckily we are now started seeing some endocardial delineation of the anterior wall. Inferior wall, we are seeing a very nice endocardium. Anterior wall is little struggle, but now is a very good image. Now he has taken, we can see the, unless you see an endocardial delineation, please do not calculate the volumes or do not even look for regional wall motion abnormality. Otherwise, you will be wrong because you will be seeing the epicardium, and yeah, that will be wrong. So we'll store this. Can we store this so that, because we have got a good 4 chamber now. So this is how it should be. The sector width should completely take up the 4 chamber. So let us take this 4 chamber, let us take 2 chamber, and let us take the 3 chamber. And at this, generally afterwards, when we will be looking at speckle tracking also, so in that case, as we know that our frame rates should be between 50 to 90. If you are lower than that, the tracking is not good. And if you are above that, again, there is a lot of noise. So we'll have the long axis view also. Is quite good, correct. So let us have the, yeah. So now we will do the summation of disk, the Simpson's method of summation of disk. Now this is machine learning. The machine can know this is 4 chamber, 2 chamber, long axis. However, we have to always adjust the points that it has taken. You should not take the tips of the trabeculae. You should take the compact myocardium, okay? Because if you take the tips of the trabeculae, you are excluding the trabeculae from the LV volume. No, across all the imaging modalities, you are supposed to take only the compact myocardium, okay? Now perfect.
So
now
let me ask you, Nitin,
Yeah.
just to start a discussion. Would you like to do the automated version or the 3-click, which is also available, or a manual tracing? What is your experience?
Yeah, actually, that 3 clicks, generally you have to do little less adjustments rather than the automated. But I think the machine learning is improving and probably in future won't. Otherwise, it does a very good job when there are good quality images. But some touch up you have to definitely do, okay? So we are not completely excluded by the machine learning. So this is correct. We include the trabeculae inside. We should be on the perfectly at the compact myocardium, okay? So we should be at the base of the trabeculae and not the tip of the trabeculae. So this is one thing. Secondly, always see that you are not foreshortening the apex. And how do you know that you are not foreshortening the apex? Generally, the apex, when you don't have an aneurysm, will be triangular. The moment you see an apex which is concave, you know that you are paraaxial, because apex has to be very, very triangular and a small angle. So this is a good long axis, and we'll look for a 4 chamber also, and then we'll get the summation of disk, which is the preferred method for EF calculation, okay? We'll not use any other method, we'll use this, okay? Only better method than this in the echocardiography is a 3D LVEF, which is little more reproducible. And you will ask me why it is more reproducible, because there the foreshortening issue is not there, because the apex automatically comes into the 3D data set. But what is the flip point? The flip side is that your frame rates are not so great. You will generally the newer machines try to give you a very good frame rates, but the 3D data set, it is very unlikely you will go to 60 or 70 frames per second.
Correct.
Okay, it is very unlikely. Always include the papillary muscle inside the LV volume. Okay, they should not be excluded from the LV volume. Okay.
And also remember that ECG is needed. Please don't use M mode for ejection fraction calculating. We still see a lot of reports having M mode, the TCOX formula.
Okay.
Right.
So, okay, you have demonstrated the modified Simpson's method.
Any
And
questions from you people? Anything. It can be any basic question also.
Yeah. Include into the volume. Include. So we go only to the compact myocardium or to the scar tissue. Everything else you include inside the volume. Okay.
So many times, I don't get especially in patients of COPD or a thin rib, I don't get this apical views very well. So can I use a subcostal view to trace this? What are your thoughts? Because
I think, yeah, only issue with the subcostal will be we really don't know whether we are in a pure long axis or not. So becomes very difficult. So I think apical views are the best.
So you should not comment on the EF. The purpose of doing it is this is very much taken in apical views. But what we are trying to get is you should have that apex to be conical. That's what is important.
And how do we get a real long axis? A very nice way is that keep the patient proper vertical left lateral, okay, and go all the way to the mid-axillary line and then start coming medially. Most of the time what we do is that we start here and then try to go laterally instead of go from lateral to medial. Then what else you can do is that generally the cushion comes in the way. So what we do is that we get a cutout done from the carpenter, okay, so that the patient lies with his left chest on that cutout. So you have got a free access to go to the lateral side, and then from lateral you come. See, many times we have a tendency that if we are not getting, we tend to make the patient tilt towards us, which is actually very, very wrong. Let him be go lateral, and then from lateral to. So just get a good cutout, and your imaging will suddenly improve. And keep on adjusting till you get a conical apex and a visually largest volume. Then there is a possibility that you are in a perfect long axis view.
Correct? But Nitin, what to do in the very extreme case of a COPD?
Yeah. Actually,
How to assess then LV volumes?
LV volume. So in the extreme case of COPD, if this particular, see most of their mass of the heart is retrosternal, and you really get a very poor images. If you try to make him really vertical left lateral, sometimes the heart comes out of the mediastinum and you can still get a good image. But if you don't get a good image, then I think introduce the LV contrast opacification. That generally gives you very good images, and it is very easy to get the long axis view there. So are we going on tracking now?
So, before I go to tracking, which is a thing.
Let us go to the LA volumes.
Yeah, so if you can wait for the tracking, I just want you to do, which we miss a lot, is LA volume, which we don't do it. I mean, a lot of people aren't doing. And also, if you can show me in the LV mass. Because, many times we just directly go and tell that it's a hypertensive
that
heart.
is a very important. So whenever tracking issue is being coming, so you will take the LA volume, LV mass, and also the LV volume. Both are coming. All are coming with the tracking, because basically we have to track everything.
Correct. So
in the LV volume, LV mass, and the LA volume. So you have to track the endocardium, epicardium, and of course the LA tracking and the LV tracking. All tracking will become. So you can discuss here, or you can discuss after that.
No, I think let us do the LA volume by the area length method rather than tracking.
Rather.
Yeah, and what we'll do is that the LV mass we'll do by M mode, and we'll do the relative wall thickness also.
Okay.
Because as we know that M mode is not at all a perfect method of doing the LV mass, but all the large population-based studies where the LV mass has been correlated with CV outcome has been done with M mode. So, but as we know, the best way to have the LV mass will be 3D LV volume, because you are getting the inner volume and the epicardial volume. You subtract and you get the mass. That is the best one. But all the outcome studies are done with M mode LV mass. So let us do LV mass, because from that we also get something called as RWT, relative wall thickness, which is a very important indicator, and we'll see how much we are going to get it here. So can we have the M mode here? We have to be perfectly perpendicular to the septum, posterior wall, and we should be going through the chordae and not through the leaflets, correct? And here we get the image and then we calculate, and the machine will with I mean the same T-cos formula will get the mass.
Don't cut the mitral valve, just
Don't
next
cut
to
the-
it.
Yeah, just
Yeah,
chordae.
perfect.
We
That's
should be
right.
in the chordae, perfectly perpendicular. Correct. Now let us have the M mode measure. And so what is the relative wall thickness?
Fridge.
Do you have that formula for the relative wall?
It will be there.
Yeah, yeah.
That's it.
It
There
will be
also
there.
it.
Probably we'll get it.
Right side.
Correct. Yeah, it will be given automatically. So can anyone tell me what is relative wall thickness? How is it measured?
So I will give you a hint. It is something for concentric hypertrophy, eccentric hypertrophy, athlete's heart. Whenever you have a thickness, whether it is because of the hypertensive guy, it is because of eccentric remodeling, or it is an athlete's heart. This is very important because once you see LV thickness, we just label it as hypertensive heart disease.
Many times qualitatively we feel that is thick, correct? But whether that thickness is at the expense of
Yeah,
LV cavity or whether it is not with expense of LV cavity, that is the issue. So what you do with numerator is your LV diastolic diameter, correct? And what is the denominator? Denominator is 2 times the posterior wall thickness, correct? So now, as you know that if, correct, that is, yeah. So as we know that if the numerator increases, that means the dimension increases and the denominator doesn't increase, that means the LV cavity dilatation is eccentric. While if the LV the internal diameter reduces or remains the same while the thickness goes on increasing, that is the denominator increases, that means this is a concentric one, correct? Now suppose if your this is the very important one, this actually looks very ridiculous that such a simple M mode can give you such a significant prognostic data. What is very interesting is this the concentric remodeling part of it. Now what happens is that if you can see these 2 lines, now below this line you have got a normal mass because x-axis is mass, below is normal mass and above is a higher mass. So this is a hypertrophy, correct? And on the y-axis you have a relative wall thickness ratio less than 0.42, above 0.42. Okay, above 0.42 is above 0.42 is what the internal diameter. Actually, I said other way around. ID because of 2 colors. It is other way around. That is the posterior wall thickness is the numerator and denominator is the internal diameter. That was my mistake. So what is important is that when it goes above 0.42, that means you have a LV cavity dilatation because the denominator is increasing, correct? While when you are less than 0.42, that means your numerator is increasing. That means the thickness is at the expense of the cavity dimension. Now suppose if you have got a mass which remains normal, like on the x-axis, this is not working.
It's not working.
It's not working. So on the x-axis, the mass is normal. However, you have a relative wall thickness which is more than 0.42. Then what has happened is that the mass is not increased, but the LV cavity has reduced. Okay, this is concentric remodeling, and this is important because this is the first step of diabetic cardiomyopathy. Okay, so diabetic cardiomyopathy. So it is pathological, though the mass is not increased, but the cavity size has reduced. Okay, is a first pathological remodeling that happens in a diabetic cardiomyopathy. You will see more in women that, and that is abnormal. Correct. Fine.
In this patient, it was, let's see, what was the 0.34 and what was the LV mass? 312. No, so 178. 178. So where does it fit? Can
So
you
where
tell me
does
where
it
does it
It
fit?
is a male patient.
178 and 0.3
Eccentric hypertrophy.
eccentric hypertrophy.
So it's eccentric hypertrophy.
Eccentric hypertrophy. So we are somewhere here. High mass and relative wall thickness is high. So we are in the, no, sorry, it is, we
Correct.
got it less, correct.
Correct, that's right.
Less. So that means your dimension has increased. So it is less than 0.42. So you are here eccentric hypertrophy. Correct.
Next, we quickly go to the LA volume because we have only 10 minutes left. Yeah.
Dr. Sengupta and Dr. Burkule, one small issue. Sometimes we see that it's a normal patient or just a hypertensive patient. The wall thickness is maybe 13 millimeters or little more or little less, but the cavity size is low, say 37, 38, 39. In these cases, visually it looks like a concentric hypertrophy, the relative wall thickness is high, etc. But the mass by this formula sometimes doesn't fit into with that criteria of 95 and 105.
Yeah.
They come out to be 87, 78, something like that.
Correct.
So what do we label them as, or what do we report them as?
They are as a concentric remodeling. Concentric remodeling, the upper one. So that means the mass is there, okay, but however the relative wall thickness has reduced, okay. So that means there is a, so this is supposed to be the first step, especially in female diabetic cardiomyopathy, and it is pathological. They are progressing towards HEP-PEP. So concentric remodeling is not a normal thing.
No, the question is, it's not concentric. It may be that the patient is non-diabetic. Indians tend to have a smaller LV cavity size.
Correct.
The question is, what should we report it?
I think still we should report it as a concentric remodeling, because we know that something is going wrong in these patients. And coupled with that, if the LA volumes are rising, then probably the patient is going in the pathway of HEP-PEP.
So this is mostly the early cardiomyopathy picture. This is not normal geometry. So don't just mention concentric hypertrophy, concentric hypertensive heart disease.
Unless there is a mass is increased.
Concentric remodeling, these people are generally very sedentary, so they don't increase their stroke volume, they
Early
don't heart rate.
HFs.
So these are very early signs. So it is abnormal.
Right, LA volume.
Quickly to the LA volume. It's very important, very important nowadays to diagnose the diastolic function, HEP-PEP, whatever may be the LA volume is not now a must thing in every routine clinical examination. Because it is one of the 4 robust parameters of determining the diastolic dysfunction, one of them.
So always remember, when you want to take an LA volume, LA should be in its long axis. Now what happens is the LA long axis is different from LV long axis, okay? So LV long axis is suppose this. Your LA long axis is at angle like this, correct? It is like this. If they were in the same region, it would have been very easy. Then you take a good 4-chamber, nice, proper LV 4-chamber, and then the LA would have been long. But unfortunately, LA is at an angle like this.
So slide is here.
Correct. So what happens is that when you are in a real nice 4-chamber that we were talking with a triangular apex, you will not get a good LA long axis. So what you do is, you go slight para-apically, then you get a true long axis. So what you do is, you get a good 4-chamber and get a skewed LV so that you will get the largest LA. So just go slightly medially so that you tilt towards, and then visually see when you get the largest LA, both in 4-chamber, 2-chamber. So your LV should look bad in a nice LA volume, okay, so that you get the largest LA volume. But LA volume has to be reported because, as you know, that is the first chamber which takes all the brunt of comorbidities. See, perfect. Now you saw much bigger. And see, the LV is bad now because it is, you can make out from this LV, this is not a true long axis. But the LA is biggest now.
Now we can increase the depth a little bit because to focus in the LA totally.
Okay. So always go para-apically to get the largest LA volume. Okay.
It is important that the LA and LV axis will never be the same.
Correct.
It will never be the same.
Never be the same.
Now tracing, you can discuss about the tracing of the LA volume.
Yeah. So while we are tracing the LA volume, never include the appendage inside the volume, never enter into the pulmonary veins, correct? So you will go from the mouth of the LA appendage on lateral side, don't enter into these veins, just go like this, and where there is a dropout in the interatrial septum, just go straight, okay? So that is how you get it. Now I think we'll get a bigger LA volume.
The funnel of the mitral valve.
Yeah, perfect. So always you should be perfectly horizontal at the annulus. Don't enter into the triangular funnel of the LA volume, correct? So that is the perfect LA volume. And this is how we got it. Now the thing is, you will get LV, what you call end diastolic and end systolic LA volume. There are 2 ways of calling it. Either you go by the cardiac cycle, where the cardiac cycle, the diastolic and systolic goes by the LV. But the LA systolic and LA diastolic are completely different. Not to have the confusion, better go by the cardiac cycle rather than the LA systole and diastole. So let us go by the LV systole and LV diastole. So when the LV systole is at the peak, the annulus gets pulled down, so the LA volume is at maximum. So at end of T wave, you will have the largest LA volume. Okay, that is end systolic, but that is actually the LA's diastole. And the smallest LA volume is after the P wave. That means after the atria is contracted. So that is at the peak of the R wave, you will have the smallest LA volume. Always index it to the body surface area. Normal LA volume, which we call is at the end systolic largest volume, which is actually the LA diastole, will be less than 34 ml per meter square. Okay, actually it is generally less than 27 ml per meter square, but they took 2 standard deviation and they brought it to 34 ml. While the smallest LA volume, which we call it as the end diastolic, because it is at the R wave, but it is actually the LA systole. So that smallest LA volume is generally less than 18 ml per meter square. Now all of us are going, and a lot of outcome studies are with the LA largest volume. But people are realizing that the LA minimum volume has got a more stronger correlation to the CV outcome, because it is like, because when the LA is contracting against the raised LVDP, it is actually like an end systolic pressure volume relationship. Okay, so that is why the LA minimum is more
important than
than
maximum
this thing. So
value.
start reporting the LA minimum and LA maximum both.
Yeah, but I think whatever he said is correct. What this machine is showing is the LS strain also. So I think let's not confuse them with the LS strain. Yeah, if you can go to the LA volume index. Yeah, so it will be more, because do you have the LA volume? Do you do LA volume regularly? Correct. And do you have a package of LA strain? In this, I'm asking them.
Yeah, I think only that is there in a very
High-end
machines.
So we will try to show you.
So volume is very
Volume
important.
is very important, and LA volume index is important.
So these very simple things,
These
like
are
looking,
small things.
small things like
LA minimum volume, LA maximum volume, and if possible, the peak systolic strain of the LA. These are the three most, I think Nitin is the most robust parameter in this at the moment.
Yeah, so peaks LA systolic, which is called as the reservoir strain.
Reservoir strain.
So reservoir strain is another very important parameter. If you're using a high-end machines, it will be very easy to get that. But volumes you will get in any lower-end machine also.
Any machine.
Correct. And as we looked at the LV, we are looking at the volumes by the Simpsons, mass by a simple M mode, and you are also looking at the remodeling from the RWT. So do not disregard RWT. Those can be very early signs of LV remodeling, which is unfavorable remodeling. Okay.
Sir, sir, you rightly said that the LA, the axis is slightly different from that of LV, and we need to modify the fourth chamber to get the maximum. But isn't it so? I mean, when the chamber enlarges, it's quite subjective in different patients. What happens when it can elongate in a slightly different, in an angle, and quite frequently we see then in a dilated cardiomyopathy like situation, where slight foreshortening of the apex, slight tilting of the probe may give the largest LA volume.
Yeah.
So,
try to take the visually the largest LA volume.
That is
that is very important.
That can vary. The angle of enlargement, quite frequently it enlarges.
Correct. So because you are using the area length method, so you want A1 and A2,
right.
Okay, and the L, okay. Now the important thing is that this A1 and A2 should be maximum in 4 chamber and 2 chamber should be maximum.
Right.
That is the way to go it. And LA diameter, the axial length should be minimum between the two, not the largest one.
Divided by small L.
We have a 5
Go
minutes.
by that 34 ml per meter square, because you guys have published a paper with the Indian normals are perhaps less than 34. So what should we take as normal for the subjects we deal with as LA volume?
Yeah, so our data in India study, we didn't do the LA volume index, unfortunately, but I think from the WASTE study, it has come up that Indians have a smaller LA volume. But if you want to still accept, I think we do use 34 ml.
Nee, Santanu, there is one important point.
One important
point.
I don't remember. Yeah.
One
Let
important
me go back. Yeah.
important point regarding that 34 issue, because it had been found that LA volume more than 32, index volume is more than 30, is associated with the increased risk of heart failure and the stroke.
Yes.
So that's why it has been cut up in 34. That is very important.
But I think our study, I don't remember. I can look back and get back to you.
We have
We
LA
have it?
volume,
Okay,
which
I
is
don't
smaller. So that is why 27 ml per meter square is actually our 2 standard deviation. Yeah.
2 standard deviation.
Yeah, because these Caucasian people are more athletic, so they have little bigger LA volumes, correct? Yeah.
Yeah, so now he's showing
Now
the
we have a
transfer.
5 minutes left for the chamber quantification, so we can quickly go to the aorta because aortic annulus is another important area I think we should discuss. Kostab, can you focus on the aortic annulus and the aorta? That is very important to because though it is been done is nowadays with the most important with the 3D and the CT, but still in the 2D how much we can offer in the whatever we can offer in the regarding the aortic annulus. Though we know that is in 20% fallacy in determining the aortic annulus from the 2D.
So whenever I do the aorta, I always zoom it up.
Yeah.
It is very important to get a good and zoom it up. That's
See, your error will reduce when you are zooming it while doing measurement. And when you do the measurements in the axial direction, they are more accurate. That axial is this. And when you are doing the measurements transversely, they are generally a little inaccurate because the ultrasound beam widens as it goes down. So the beams go, as they go down, they keep on separating from each other. So that is why the horizontal measurements are inaccurate, but the axial ones has the greatest resolution. So these will be correct. Second thing is that this is your right coronary cusp. Now downstairs, I mean this side, you will have, actually you should be in the commissure of NCC and LCC. So in systole, this leaflet should slightly vanish. Yeah. Because there you will be in the commissure, while the RCC should be seen well. Otherwise, what happens is if you look at the short axis, what must be happening is that you are slightly skewed. That is, you are through RCC and going, see, somewhere the leaflet should vanish.
Vanish and systole.
In systole, yeah. It should vanish. It should not look as beautiful as the RCC.
Just freeze
that
it.
means you are there in the real, correct. I think that was correct. You were, you lost
fine,
that.
fine, absolutely fine.
Freeze it.
Freeze that, freeze
Just
that.
go frame by frame.
Frame by, just go back.
Go to
back.
mid-systole.
Mid-systole,
back.
where this leaflet is not should be seen as good as this.
That's it.
No, RCC you should see well. RCC you should see well. Yeah, correct.
Yeah.
I think that was good.
That is
this
good.
was slightly go behind again. I think there was one more frame where you had correct. See,
correct.
you are seeing it here, you are not seeing it here because you should be in the commissure of the NCC. Otherwise, it will go slightly oblique. Still, we are much oblique than the CT. You should take the hinge points for the LVOT diameter. Okay. Now that we take as an annulus, but as we know, it is pseudo annulus. It is not the true annulus. The hinge point is not a true annulus because the actually anatomically the true annulus would be where the muscle ends and the fibrous tissue of the aorta skeleton starts. That is generally above this point, which on the echo we cannot make out. That is the true annulus we cannot make out. That true annulus only the CT sees because they can make out where the muscle ends and where the fibrous tissue of the aorta ends. So what we take is a pseudo annulus, but that is for all practical purposes correct, and that is at the hinge points in mid systole, correct? However, all the sinus of Valsava, sinotubular junction and the aorta should be taken in diastole. And here you take it inner edge to inner edge for the annulus, while for the SOV, ascending aorta, you take the leading edge to leading edge, okay? So you take this to this, leading edge to leading edge. You don't take inner to inner. And why you don't take inner to inner? Because the CT diameters are done that way, and then you are a little more closer to the CT diameters when you took leading edge to leading edge in diastole, okay? So you should be giving annulus, sinus of Valsava, sinotubular junction, and ascending aorta.
Measure.
All in diastole.
In diastole,
except
the annulus should be mid-systole.
Mid-systole.
And annulus is only inner edge to inner edge. Okay, and always remember what we call as annulus is anatomically not the true annulus.
I think we have to wrap up the chamber quantification now because already 45 minutes, 50 minutes have been gone. So we have to next to the next.
But I think one point we made
Any
is that
point, any
LA
questions?
enlargement should not be by just looking at the diameter. It should be always volume.
And yeah, you had a point. That is annulus.
Annulus, but you generally take it as a LVOT. See, there was a confusion whether to you take that annulus versus go 5 millimeter down and take the LVOT.
more or less
Now the problem is that the posterior part of the LVOT is made by the anteromitral leaflet, which keeps on moving. Okay, so that is why The stationary point is actually the annulus. So better to take that annulus or whatever LVOT diameter and annulus the same for your calculations of aortic valve area. Okay, because that is much more reproducible rather than taking 5 millimeter below that hinge point, because the LVOT keeps on changing because of the IML motion.
On echo, it is very difficult to differentiate on a on
Chandrima, next, what is the next topics? You can announce from there, no problem. Wait, in the mic, in the mic, in the mic.
any case.
Yeah, we will go on to the next topic, and we have cardiomyopathy to continue with.
You have any case on cardiomyopathy?
Yeah, we can do the same patient also.
Just give me a moment, sir.
Yeah. Any questions? So we will just continue theoretically on the RV also. You can just mention about RV by the time RV you can just show.
That is the important slide. You can, Santanu, you can tell
Yeah, I
about
think
regarding
this
the
is
RV.
the RV. We generally do the RV systolic function and RV sizes. We don't do RV diastolic function because it is still in research and I don't know what is the value. And there is something called RV focused view. So wherever you get the longitudinal fibers from the apical views, you start looking at the RV focused view. I think next patient we will show how to do the RV focused views. And I generally, I mean, of course, we have to do measurements, but normally the LV is bigger than RV. But the time when RV looks similar size, or if the RV is bigger than LV, then it is very important to get this sizes. And that is at the base, mid, and then the long axis. So the base is not the annulus. There is something different than the tricuspid annulus size. It is just above it, the base RV dimensions, the mid and the long, starting from the apex to the mid of tricuspid annulus.
And the other one is the LVOT, which is much, RVOT, which is much more reproducible. And if you see the arrhythmogenic right ventricular cardiomyopathy, major criteria are on the LVOT diameter, because that is much easier to do. Rest of the RV on echo is very subjective. But LVOT, RVOT in long axis and RVOT in short axis, okay, are very important measurements for the ARVC diagnosis, okay, and those are 27 and 32 millimeters and so on and so forth are the cutoffs. So this is important, and also pulmonary annulus you should take. Now the thing is, RVOT diameter is always taken as pulmonary annulus diameter. It is never taken, because RVOT is a muscular chamber. It keeps on changing the size. So whenever you want to take an RVOT flow or pulmonary flow, the pulmonary annulus is the way to go, because that is only fixed point, correct? So that is why that you would be doing for the, say, PA flow if you want to have, then that is the way to go. But remember, don't forget to look at the RVOT. And why it is important is, even subtle pulmonary embolism you will pick up just while you are taking the, parasternal long axis view. Because, as you know, the LVOT and RVOT are perpendicular to each other. So when you are taking a P lax, RVOT is in short axis. And you can visually look at the contractility. And many times the moment you start slightly biggish RVOT and not contracting well, immediately think of an acute pulmonary embolism, and you will pick up a lot of them, okay? Or in the patient with the palpitations and so on and so forth, we generally just look at the MVP, LV, but rather look at the RVOT. Okay, if you see a biggish RVOT, immediately take those two measurements, because you may be catching up an ARVC.
Nitish, another important thing is that to measure the RV wall thickness, because to tell you the RV hypertrophy, because a lot of things we have been discussed about the LV hypertrophy, but clinically, but means easily we can determine the RV hypertrophy by measuring the free wall thickness. You can any point about it?
Yeah, so the free wall thickness of the RV, always do a subcostal view. Don't use the long axis view. Do a subcostal view, and you have to do it before the papillary muscle here. You have to avoid the papillary muscle, okay? And then take the thickness of the right ventricle like this. And generally 4 millimeter, I mean, generally they are 2 to 3 millimeters. Anything 4 millimeter and above is RV hypertrophy. But let me tell you that
Nitin, to call it RV hypertrophy, is it 4 millimeter or it has to be more than 6 or 7 millimeter?
Above 4 millimeters.
Above 4 millimeter.
4 millimeters, okay. Yeah. So, but only thing is, I'll tell you, there is a pitfall here. Many times you have got a very packed epicardial fat pad. okay, and which sometimes have the echogenicity like an RV, RV wall. So we can sometimes get mistaken by taking that fat pad inside, okay. So that's
But
why.
the another important parameter you can briefly tell while preparing the patient.
So the other one on the echo, very quick one, is obviously the TAPSE, the tricuspidal annulus displacement, okay, systolic excursion, tricuspid annular plane systolic excursion, and it is very simply done by the M mode. But always remember the M mode should be as parallel to the motion of the annulus as possible. You don't go very skew way. And then you measure the peak and the nadir, this thing, and generally it will be more than 1.6 centimeters or 16 millimeter, anything, 17 they have taken it, yeah, 17 millimeters, it should be less. Anything going above this, below this is a dysfunction. Another one is that we can take the pulse wave velocity there, and the cutoff is, generally I remember is a 10 centimeters, 9.5 is very difficult to remember. And the RV free wall strain. Now this is important, RF free wall strain, do not introduce the septum into it, because septum generally works more with the left ventricle. So take the RV global free wall strain. Generally it is more, it is generally you will get it 24, 25, that kind of a thing. The moment you start getting it 20% or then you start thinking that there is an RV free wall dysfunction, okay.
So these are the three important parameters. If we can include in our routine echocardiographic report, then you can give a fairly good judgment about your RV. And these three are very, very important.
And very interesting.
And I do routinely, at least I try to do it.
And this RV free wall strain actually has a much superior prognostic value than even the RV volumes by the 3D or by this cardiac MRI. This RV free wall strain has got much, because for the simple reason, because RV free wall strain looks into the myocardial contractility, unlike the volumes which can be because of many other things, okay. So that is why instead of volume and RV-EF, RV free wall strain has got much stronger prognostic data for the mortality.
Yeah, so the question is whether to use fractional shortening imaging. Now the problem is, it is also a good parameter, but it is all dependent upon the alignment of the fibers. To make you understand this, that in RV, looking at RV in apical long axis view, predominantly 90% of the RV fibers are longitudinal. And in outflow tract, it is only 10%, which is mostly circumferential. Fractional change by 2D doesn't give you exact representation of the volumes, because it is very difficult to get the volumes of the RV by 2D imaging. It is by 3D imaging.
Only.
And they have said that the RV strains and the TAPSEs and the RVS prime has been correlated well with prognosis.
Exactly.
So fractional shortening can be done, but
these three are more important.
Too difficult to acquire.
We don't do it because there is a lot of variability. But
if Sulogna is getting ready, by the thing, another important area is IVC.
Yeah.
Then because in day-to-day practice, you have to have your IVC measurement and the collapsibility in your day-to-day life, not only in the cardiology, in every ICC units. Right. In fact, in every emergency where they exist, because you have to find out the volume status of the patient. And nowadays, I think for the last 5 to 10 years, in fact, all the clinicians are asking about specifically writing the IVC status. So even if you do not give the report, they have to force you to give the report. So it is very important to give the IVC. So I think you can discuss in the same patient, even in the IVC. So these are the chart you can tell, and this chart is very important, everywhere is written. But anything you want to tell extra, Nitin?
See, the best way to remember this is that whether the IVC size and the respiratory variation are concordant or discordant. Like, you don't have respiratory variability and the size is bigger, so concordant. That tells you that there are very high pressures. And concordant in other direction, that the IVC is less than 17 millimeter and the collapsibility is more than 50%. Again, a concordant. That means the pressure is very low, 3 to 5 mm. So that way you remember. And when there is a discordance between the two, choose a figure between 8 to 15. Okay?
Now, you had a question, then I will come to the IVC. Yeah. Right. So It is now turned to 1.7. 2.1 has
1.7 or 2.1?
It is 1.7 is being taken. 2.1 is for the European thing. And in Indians, we have also seen it is at a lower stage.
Correct.
So go for
And
1.7.
athletes and especially swimmers, they have large IVCs. Okay, so there you give some concession to 21 millimeters. Somehow I don't know, but I mean the very competitive swimmers, they have got very big IVCs, and they even have a little bigger RA and RV chambers. So always look at. But those will be collapsible, though they are very big. Okay, so are we going for
the
a,
IVC?
Nitin, in fact, in the Roberto Lang's original article, in the two places it has been written to twice. Once in the literature it is written to 1.7, and in the chart it is written 2.1.
21? Yeah,
2.1.
2.1.
2.1.
But as our day-to-day practice, 20 millimeters are generally enlarged, except he is a
1.7 would be the consensus, na?
Pretty good,
Now it
yeah,
should be the
unless the
consensus.
swimmer you give concession because they really have big IVCs.
So now the question is where to put an M mode on the IVC. So for this, she is rightly showing the first hepatic vein.
Correct.
And if you can put the M
So
mode,
always measure it before the entry of the first hepatic vein. If you don't put it at the IVC RA junction, okay, you should be before the opening of the hepatic vein. Correct.
the other side.
Yeah.
Other side, this side, before it enters.
Don't
correct?
go towards the heart. Go
Away from the heart.
from the heart, beyond the first hepatic veins. Don't go to the second hepatic veins or third hepatic veins, because then the abdominal pressure starts compressing the IVC.
And so this is how it is, and
That's nice.
it is, I think, probably is enlarged.
It is
I
enlarged,
think
yeah.
enlarged.
21. So
And
it's enlarged.
many times what happens is that when you are looking it in a longitudinal direction, the IVC may move in and out of the imaging plane, and you may feel that it is collapsing. So it is better to confirm it again in a short axis. Okay, so in that chance, then the chance of the IVC moving out of the imaging plane is much less there. Okay, so you know the collapsibility there. But I think it is a very simple and important bedside measure. Correct. So there are two things that since we are on higher filling pressures, there are a few simple things that you can look at it. Especially the ICU patient. One is your IVC.
Right.
Always, as a echocardiographer now, always start looking at the lungs also. Okay,
the
it should be
maximum,
your
take the
routine to
minimum.
look at the lungs especially the ICU patients. Okay, actually we carry our Vscan with us on the round, and we scan everybody's IVC and lungs also. So lungs, look at the IVC, just go here, look for the right pleural effusion, go here, look for the left pleural effusion, and diaphragmatic motion. Many of these post-CABG patients may have diaphragmatic paralysis and breathless, and people are doing all sorts of investigation. It is simple. So just look at the diaphragm motion, IVC on either side, pleural effusion on either side, and then just go on to the second intercostal space, and then the third intercostal space anteriorly, second intercostal space, third intercostal space in the mid-axillary line on both sides to look for the lung comets. Okay, the lung comets is a very sensitive indicator of pulmonary edema. It surpasses the X-ray pulmonary edema, it surpasses your clinical examination of Krebs, and so on and so forth. So let us show
we are
the
showing
lung
the
comets.
lung. So
Yeah.
you know so we are doing the lung ultrasound. We're just slightly moving away from it. It's very important. Now we are using the echo probe. We can use the other probe also. So if you can see here, you are seeing the pleura. So you have to decrease the depth. Decrease the depth, decrease the depth, decrease the depth. So normally the lung will show you A lines. A lines means it will be, so this is the pleura. Just
Pleura.
keep
See,
it.
you can see why it is pleura.
I will
He's
just-
calling it because the visceral and the parietal pleura, they are moving with each other. You can see that with respiration, they are sliding over each other.
See
Can you see that they are sliding?
Yeah. See what
Okay, that is a very important sign that tells you that there is no pericardial, the pleural pathology. And what happens is that this pleura continues to have reverberation here. So you get horizontal lines like this going down, and that is the normal lung tissue. The moment you have any kind of edema below this visceral pericardium, you start getting the lung comets.
That is the big pain.
That is the thing.
The B line.
And it's a very sensitive sign of pulmonary edema. And if you give your diuretics as per this pulmonary edema, I'm telling you the patient's readmission rate will reduce. Okay. Even before discharge, look at the lung comets and step up the diuretics accordingly, and you will really reduce the hospital readmissions, because it works much better than JVP, Krebs, X-ray chest and everything. Okay, so we have something in the hand which is powerful. We have got an echo with us, but use it for lungs also. Okay, that will tell you about the filling pressures.
So what I did was, because the echo probe, the penetration is different than the linear probe. So we have to decrease the depth, and the first thing is keep your hand very still. And there are 4 zones on the right side, 4 zones on the left side, and you can also do posteriorly. What are the 4 zones? If you have, if you put a line in the parasternal and in the anterior axillary line. 1, 2, 3, 4. 1, 2, 3, 4. Generally, the 3 on the left side coincides with the heart, so it is not very much helpful. Normally, you will always get a pleural sliding. Whenever you keep it, the pleura should slide normally. Shimmering, sliding, lot of names online. Okay, that's one. That is also helpful in telling whether the person is alive or not. I'm telling you, that's very important, because whenever we declare, these are few things, whether the heart is moving, because many times the hearts have this blood. That is one. Second, this is a normal A line. A lines on the lungs, and B lines are basically artifacts. Whenever you start getting some edema, any fluid, it will be like straight lines. So presence of 3 straight lines in one zone, second zone, it indicates presence of fluid. Correct?
Correct.
Okay.
So, but it is very sensitive for pulmonary edema, but not specific, because even something like the lung involvement or pneumonitis related to, say, COVID, and also can also give this shadowing. Now, why you don't go posteriorly? Because generally there is a dependent edema.
Very different.
Yeah.
So why you do it in the anterior and this anterior axillary line? So you do between the anterior axillary line and mid axillary line, that zone, and between the anterior axillary line and the mid clavicular line.
Mid-clavicular line.
Yeah, because they are anterior ones. So there, if you get edema, that means definitely the wedge pressures are quite high.
Yeah.
So that's and we see this also in the patients of HEPF after treadmill stress echo. At peak stress echo, we immediately scan, after looking at the regional wall, we immediately scan for the lungs. And you will be surprised to see some of these patients develop new, signs of the comets. And that is a very strong indicator of acute rise in LA filling pressures. And that can explain the patient's dyspnea on exertion or exercise intolerance. Okay, you may find it very outlandish, but once you start doing it, you really find it. And I think that is a most important indicator of rising LA pressures, rather than doing all those E by E primes at peak exercise, which are very difficult. Just doing the lung ultrasound.
One funny thing, one important thing, if you label, if you do lung ultrasound, give it as a separate report and you can charge for it. I'm telling you, it is a very, I'm just putting a probe, you can say whether there is A lines or B lines, and you can charge.
But
So,
all casualty patients, all
Everybody.
emergency room patients, all ICU patients, when you see the echo, also scan the lung.
Scan the lung.
Okay. 100%.
So we are at parasternal long axis.
And actually, if you see suddenly on the lung, while you are seeing it for the pleural effusion, suddenly if you see like the tissue which looks like liver, then you know that there's a consolidation also. Okay.
I think it is a valvular case.
It's a valvular?
Yeah.
It's fine. I mean,
Oh, we'll go to the valvular now. It is now, actually, we thought it is a cardiomyopathy. Okay, anyway, no, it doesn't matter.
no worries. No worries.
Okay.
We
Okay,
can-
okay.
whatever.
So we'll go to the valvular now.
No, but I think in the cardiomyopathy, we wanted to discuss regional wall motion and all those things.
No.
Okay. Fine.
ठीक है,
Fine.
whatever is, whoever is sleeping, we can.
Okay, we'll now
Yeah, so let us go to the valves.
valvular.
Now, one important thing is what has happened is all our machines start with harmonic imaging. Now, harmonic imaging has got a lot of blooming effect on the leaflets. So, never talk about thickened walls when you are doing a harmonic imaging. All walls will look thick, correct? So, and the lower the frequency of transducer, more thicker they will look. Correct. So actually the thickness should be in a fundamental imaging, and many of us always start with the harmonic imaging. Okay, so that is one thing, remember. Okay. Okay.
Yeah, so you can see on the right side there is a frequency called 2.0.
Yeah. See, suddenly it starts looking thick now. And while we are doing a valvular heart disease, as a clinician, I would advise that go through everything, clinical examination, ECG, X-ray. So you know that there is a cardiomegaly, no cardiomegaly, you are auscultated for the murmurs, and then you start echo. Always start with pure 2D, do not put color Doppler. You put color Doppler when you have made your mind and then put it, okay? Because there are simple things on the 2D. You look at the volumes. We did the volumes first. So from the volumes, you know whether the that particular chamber is pressure overloaded, volume overloaded. So you know that there is a regurgitant lesion, no regurgitant lesion. Look at the wall morphologies in 2D. We have a lot of hurry in putting the color Doppler and we miss a lot of information. Okay, and color Doppler is not an ultrasound angiogram. Okay, just by changing the variance, by changing the Nyquist limit, you can create mild MR into severe MR. So what is important thing is that first look at the cardiac volumes, which are actually the HbA1c of the LV volume overload for chronic disease, correct? So look at the volume overloads, look at the wall morphology. Even if it is an you know that there is a probably an MR looking at the large LV volume, hypercontract LV. Try to look on the 2D image the mechanism of MR, because now your surgeons are going to repair it, you are going to have people for mitral clips, so on and so forth. So now make it a habit to look for the mechanism of mitral regurgitation, and so also mechanism of aortic regurgitation. Whether the mechanism of AR is because of annular dilatation, root dilatation, or fibrosis and retraction of the cusp, flail cusp, so and so forth. That will give a wealth of data. So make think as if color Doppler is not existing, make up your mind, and then turn the color Doppler on later on for the quantitative measurements.
Yeah, so I think we are looking at the mitral valve disease and also an aortic valve thickening. I'm interestingly seeing that once we switch off the harmonics, the frames go very down.
Correct.
Right.
So looking at this LV, the size is slightly higher. Definitely it is higher, correct? We know that there is a definite stenotic lesion which looks significant because the separation of the leaflet is very poor. This is definitely rheumatic, PML is and there is a calcified one. And I would also like to know whether the calcium is there in the commissures or not. So we'll look it in this particular view, we'll just tilt medially and laterally and see whether there is a calcium in the commissures. If you tilt medially, you will see the medial calcification. You tilt laterally, you will see lateral commissure calcification. Then you will see in a short axis view, and in the short axis view, you know that the calcium is not in the commissures, it is at the edge of the leaflet. I'm very happy with that. So this is though this is not a pliable wall, at least it is not bad for the balloon. That is one thing. I know looking at it is a significant one, but I know that the LV has some dysfunction and dilatation. Whether I am also dealing with some amount of MR or AR, that is what I already have made up my mind to look at. Then I will look at the aortic wall little more carefully. So let me see for the long axis view of the aortic wall, zoomed one, so that, okay, short axis also you can zoom, just zoom the wall so that I know the mechanism, whether I'm going to expect a severe AS, I'm not going to expect the severe AS or AR or something like that. So in a short axis view, let us look at the leaflets. Looking at the leaflets, I think there is a central non-cooptation zone. So probably I may get some ARZ there. I doubt whether there is a significant AS because there is not much hypertrophy of the LV and the leaflets are separating. So all this information you make it into mind. Look at the LA. LAs are quite big. So I know that the LA filling pressures are going to be very high. I will look at the RV. LA is quite big, definitely, even if 4-chamber. I'll start looking at the RV, and I will start looking at the RV function and tricuspid annular diameter. All left-sided lesions always mention the tricuspid wall annular diameter, because that's the only chance to repair the tricuspid wall when he's going for a mitral wall surgery. Later on, if you fix up the mitral wall, aortic, everything, and then the patients come with a severe TR, then you are going to have it, because surgery primarily for severe TR has got a 50% mortality. So it's best that whenever you are going for the left-sided lesion fixing, don't look at the volumetric TR, but look at the tricuspid wall annulus. Because the moment it gets remodeled, even if you have got a mild TR, it is going to keep on progressing, even when you fix up the left-sided lesion. So you look at the tricuspid annulus remodeling rather than the volumetry of the TR, because the TR volume changes within minutes,
by a change in the preload. Okay, so you may see even almost a trivial TR when they are anesthetized and you are doing intraoperative, and they come to the ICU and there is a florid TR. So you have missed the bus if you don't put a tricuspid annulus that time. So we'll look at it. We know that this is thickened. The cooptation is bad. I'm going to have a TR. Okay, there is a RV function is well preserved. I will measure the tricuspid wall annulus. If it is more than say 26 millimeter per meter square or 40 millimeter for that matter, it's better you alert the surgeon that he will have to put a tricuspid annular ring, even if the MR is mild, okay, or on color Doppler, because it's going to progress. We have this wishful thinking that once we have reduced the transmitral gradient by, say, putting a wall there, the TR will reduce and everything will be fine. It's not that. Okay, so we saw that there is a TR. We expected it now. We expected at least a moderate TR there, and we knew it. Now let us look at the mitral also. Let us look at the mitral.
And how to assess the severity of the mitral stenosis? That is the most important thing.
Correct, right. But I think now you can have
Yeah, you can tell about how to assess the severity of the mitral stenosis.
So let us look at the flow across it, and let us search for any MR there. Yeah, you have some MR. I think, see, that is, we were looking at some volume overload of the RV. So once you see the MR, probably you will take multiple unconventional view to see the extent of mitral regurgitation. Then you will not miss it. Okay. So no pathology is going to lie in your standard views. You will have to take a lot of unconventional views and look at the MR in multiple different views, correct? So that is one thing.
Central MR, eccentric MR,
Eccentric
commissural MR.
Then let us look at the color Doppler qualitatively for the aortic wall.
Not much of stenosis.
Yeah, there is probably little adjust the gains, adjust the gain. Look at a short axis also. Correct. So in that case, now see how you build up the case. If both the regurgitant lesions were not that great, why the LV is dilated? And the answer is here. That is probably it's a chronic AFib which has remodeled the LV. Correct. So now you have an explanation for that. So that is how. It's a simple way of investigation. It's a very interesting. Doing an clinical examination and echocardiography is exactly akin to doing a Sherlock Holmes work. You are putting the pieces together and getting explanation for everything. Okay, so that is why that RV is dysfunction, LV is dysfunctional and dilated.
Also has severe TR.
So the thing is, what would have happened otherwise, that if you are not thinking that way, then an MR which is not in the standard plane, you can miss. Now you diligently look for MR in all the possible views and say probably this, and don't go by the extent of mitral regurgitation or the area that it goes into the LA. Always look at the origin of the jet. Yeah. Origin of the jet is the much better semi-quantitative way of looking at this thing, because origin of jet thicker, a larger pizza even at normal Nyquist limit will tell you that this is a voluminous MR. Here the origin is smaller. I am not seeing any pizza at that 60. So I know that this will not be voluminous. Okay. So also for the AR, look at the origin of the jet. That's the best way of semi-quantitative way of looking at it. Rather than looking at the extent, how much the AR goes into the LV, those are all useless things to do. Look at the origin of the jet, okay? And now we have got the explanation for this dilatation is because this is the remodeling related to the AFib. So probably he had uncontrolled AFib episodes which had caused the tachycardiomyopathy. So though now he is 90, probably there may be episodes throughout the 24 hours where he may be suffering. So that has got another clinical impact. So how much wealth of information echo gives you? That means now I will be more careful about controlling his even heart rate also. Probably I'll bring it down more in the office, because then throughout the 24 hours, because you have to relieve the LV.
Very, very important.
Why is he getting this kind of...
So that is why you fall in love with echo, because you know that is an extension of your clinical examination and so much insight it gives into the patient's hemodynamics. No other imaging modality can give you like that in real time and multiple times without harming the patient. Okay, it is like a stethoscope only. Okay, so we got that information, and then
Now let's this case be assessed. How much is the mitral stenosis? How much is the mitral regurgitation? How much is the aortic stenosis? How much is the aortic regurgitation? And how much is the TR? In this particular case, how to assess?
I think they have got a very
First come to the mitral stenosis. How much is?
Now first thing is they got a very good aortic flow.
Come to the aortic valve.
Aortic flow. You can see that the AR, now remember, now this AR PHT or whatever the deceleration time here is quite flat. We know that it's quite flat. Actually, when the LV dysfunction occurs, the LVDP, the LVDP will rise, and this will be little, so even at a mild to moderate, it will rise. Here it has not, so that is a very good sign. That first tells me that the AR is not voluminous, and secondly tells me the LVDP is not rising to that extent. So this simple piece told me that even his LVDP is good, and probably the mitral stenosis is still preventing the LVDP to rise. So that is one thing. Secondly, in the AS, what happens is that you may not be parallel to the aortic jet always, okay? But what that doesn't change is the ejection time of the aortic envelope, okay? The aortic flow envelope. Always look at the ejection time and divide it, acceleration time and divide it by the ejection time. If you have something which goes, say, more than 0.35 or goes to 0.4, you know that if my peak gradients are not high, but if my ejection time to the, acceleration time to ejection time is high, that means I am not aligning. So even if you are not aligning, these time intervals are not going to change. So that is why always look whether you have got an early picking gradient. Now here it is almost early picking because it is almost less than 1/3 of the systole.
Even the shape of the envelope.
Yeah.
Shape, yeah.
Yeah, just look at this. Okay, see if it goes, the peak velocity comes somewhere here, we know that that we are underestimating the velocity because we are not aligned. Okay, so that
because of the
these
alignment.
times are so
Yeah.
important.
So that we know.
These
are
are
not going
so
parallel to the
important
flow.
looking at. So look at these envelopes, they have got so much of information to tell you. Then look at the spectral broadening. You have got a lot of spectral broadening here. That means the RBCs are moving at different velocities throughout the systole. But in AR, you don't have much spectral broadening. That means the thing is, that means the AR is not that voluminous. That again tells you. So many qualitative things you can put them together, okay, looking at all this.
Are you guys understanding what we are talking? Yeah, okay.
Correct, yeah. So, Dr. Natesa Pandyan always says, everything in Doppler means something. And it is really, really true. And Doppler, CW Doppler, has got a 5 millisecond resolution. No imaging model is going to give you that kind of a hemodynamic. 5 millisecond is unbelievable. Okay, 5 millisecond intervals it is showing you, nothing. All these high ends, whether it is cardiac CTs, cardiac EMA, they are all 40, 50 milliseconds, okay. They will miss so many events. 5 milliseconds, so that is why it is so important. Okay, I think here we see.
We can conclude this patient is not having.
Now here what I would like you to do is that we see the velocity time integral of aorta and we'll see the velocity time integral of LVOT2. And look at the ratio, which is the dimensionless index, correct? So this
Particularly in presence
dimension,
of mitral stenosis.
pardon, sir?
Particularly where this patient is having the
Having a
mitral
mitral
stenosis.
stenosis.
Mitral stenosis.
Yeah, because what he's pointing to is that you are looking at a low flow setting.
CW will not
Okay,
get it.
when you have got a mitral stenosis, you have got a severe MR, you are robbing the stroke volume. Plus he is in AFib with
PW
LV
and
dysfunction, so it's a low flow, low gradient. So in that case, having that dimensional index is important. Now this is called as the DVI, Doppler Velocity Index. Now the basic principle of DVI is that take a proximal flow as your numerator and the distal flow as your denominator. So when you are doing a DVI for mitral, the same thing. Mitral flow will be numerator and the LVOT flow will be denominator. When you are doing it for aorta, LVOT DVI will be numerator, denominator will be the aortic flow, correct? So this DVI index. So for the mitral side, it should not be more than 2.5 and on the aortic side, it should not be more than 0.3.
That's fine, that's fine. Yeah. So LVOT VTA is 12.7.
Now here, I would just advise little more like this, that what I would do is that, see here again, see, I don't know in Calcutta what is the housing situation, but in Mumbai we know we strive for real estate. So we strive for real estate here also. So what we do is that we take, now for LVOT I will take this baseline here, okay, and I will try to use this entire real estate for my Doppler gradient. So what I would say, take this up. Baseline up, take the baseline up, bus. Now I got a big real estate, then I will reduce the velocity, peak velocity, so that this comes down here, this does come down here, and what else I am going to do is that reduce the velocity further, reduce the velocity further, till it reaches almost here. Good. Now what you do is that you don't know when it is reaching the baseline because you have a filter here which is excluding all the velocities on either side of the, so I will reduce this wall filter. Just bring down the wall filter so that you know where it is reaching. So bring down the wall filter while you are acquiring. You will have you will have the low, you will have that low velocity filter there.
The MS.
Yeah, you have that, correct, correct, that's the one.
Correct.
Perfect. And now you put it at a very high swift speed, very high swift speed. This will reduce your inter-study and study-restudy variability. Okay, and if all the people in your echo lab are doing this way, you will have the same AVA measured across, correct? Because now your error of velocity time integral will be very less. Correct? Okay, so all of you know the importance of the real estate. So, you know, this is a real estate you have
Excellent.
So what he has done is he's decreased the baseline. That millimeters per second, that thing.
Now this will be much more reproducible, much more reproducible. And then what you do is always take only the outer diameter of the modal velocity. Okay, yeah.
So,
yeah, he'll explain.
so what he has done is, first we put a PW at the LVOT in apical 5-chamber view. Once you get a PW apical 5-chamber view, decrease the velocity gradient. So it is now only up to 0.8, so that the envelope is bigger, and decrease the scale.
Correct. And you are taking the
Also
baseline up.
up.
And swift speed more.
Swift
So
speed.
now
So you get only two
so now
images.
when you are doing a velocity integral, you will have much better reproducibility.
Bigger and broader, so
Bigger
the
and
chance
broader.
of error is less. I think so. That is the basic.
Correct. And secondly, always only take, see what does this intensity of the spectral Doppler tells? It tells you that the number of quantum of RBCs moving at that velocity at that point. Okay. So that is why you always take the outer border of the darkest spectrum. Don't take these serrations. Okay, these serrations is called feathering artifacts. Many people will give you a wrong peak velocity because they take these feathers. See, these feathers should not be taken. Okay, so these are feathering artifacts. So always take the quantum of RBCs inside the spectral Doppler. So everything in Doppler is so important. And now you got velocity time integral, how much?
12.3.
12.3. And how much was the aorta? Do the same thing for the aorta.
Aortic envelope.
Yeah.
Okay. How much?
He already has given me. Yeah. Now
Yeah.
here also.
55.7.
Correct. So 20 by 55. Na?
50. 0.25. 0.50. 0.50. See, it's normal almost.
Okay. Now what you do is here also, whenever I'm looking at the aortic, what I will do, I'll take this, baseline here. I will go on a very first, I'll reduce the thing so that I get a very large envelope. And that large envelope, when I measure, my study-restudy variability is hardly anything. Okay. See, the significance of the this DVI, Doppler velocity index. Okay, so see, the thing is, it's like this. If it goes below 0.3, what does that tell you? That is the denominator is bigger, so that the velocity time integral of the aorta is quite large, while that of the velocity is quite less. Okay, so that tells me that there is a significant aortic stenosis. Now, what happens is that if I get a higher gradients because of, say, increased flow across the aortic wall because of, say, anemia, tachycardia, thyrotoxicosis, anything like that, then both the flow LVOT will increase, so also proportionally aortic flow will increase. So that ratio won't go down.
55 is coming soon.
How much is it?
55.
55. So 55 is normal. I mean,
How much was earlier?
so anything start going below 0.4, be careful. 0.35 definitely significant. 0.3 to 100% significant.
Is normal.
Severe man.
Severe man.
And another thing, I mean, this is not aortic stenosis of that severe, that is nothing. Another thing which we like to add is stroke volume.
Yeah,
All
and see, now since she had made it long, you can see it's a very triangular one, early triangular picking, so it's not significant. Most of your severe aortic stenosis, they will be, tongue shape, that means they will be parabolic. Okay, and the simple clinical examination, you know that the late picking murmur. So same thing, here it will be late picking. Something going to almost 50% of the systole has to be severe. And now that time you get a peak gradient of, say, only, say, 2.5 meters. That means we are not aligned.
Yeah.
But the acceleration time to ejection time ratio will not cheat you. It will tell you that you are wrong, but it is significant. And this works for even low flow, low gradient severe aortic stenosis also. Yeah.
Yeah,
But
that's
then,
it.
then as Shantanu was talking
Then
of
the
stroke
DVI,
volume, so he'll come to the stroke
DVI
volume.
index will be helpful.
DVI is very important.
Let's
because-
see that stroke volume. I mean,
DVI
that-
index will be
So
helpful.
he's a low flow, low gradient, and the DVI is quite good, and the stroke volume you are talking. Yeah.
But I
Sorry.
think the point is in the presence of, I don't know, let's say this is a moderate MS or severe MS, we don't know. We didn't quantify.
We probably may not be very significant.
May not be significant. Let's see what is the stroke volume. The
Okay,
stroke
okay, find out the.
Yeah, stroke volume is nothing but LVOT diameter square into 0.785 into VT LVOT. And we get,
So we
So
got a
with-
23 millimeter, we got some 0.9, and no, sorry, VTI we got 1 square centimeter. And what was the stroke volume? Let us look at the stroke volume. The LVOT trace will be having the stroke volume. Or no, if you go into the measurements, it will
Measurements,
have
you
that.
will get everything.
No, in the measurement package, you will be having it calculated.
You go to the measurement package.
Yeah, here somewhere the stroke volume will be. Yeah, stroke volume indexed is 28 ml per meter square. So it's a low flow.
Low flow. Still a low flow.
less than 35,
30.
34.
Yeah, anything below 35 ml is taken as low stroke volume. Secondly, what we can do now, let us look at the total stroke volume. How much is the total stroke volume? 50 ml.
50 ml.
Now, this 50 ml is ejected in a particular time. So, if you take the numerator as the total stroke volume divided by the ejection time, what you get is a flow rate. Okay, because you are normalizing it to per second. Now, the systole occurs within milliseconds, but you normalize to seconds. So, how much was the ejection time? So, 50 ml I know is the stroke volume, and in how much time it is ejected? Let us look at the ejection time. Let us go to the aortic. No, you go to the aortic tracing and just go to the aortic tracing and just take the ejection time. How much is the ejection time? Just take the time caliper. Time caliper.
Generic.
Time caliper.
No,
No, you go into the time caliper and.
This is not.
No, take the aortic. Take the
Aortic.
First, go to the aorta here. No, just go to the aorta first.
18th image.
Just go to the aorta, aorta flow. Yeah, or you take the bigger one.
18th image, yeah.
You
take
and
the-
just measure from here to here what is the time. Just go into the time caliper, generic time caliper, and just measure from this click to this click. You get the opening click, you get the closure click.
Correct.
So what more you want? Closing click, edging. So nothing it's giving. So how much?
A little more.
285 milliseconds. So that is 0.28 seconds. So 50 ml divided by 0.28. How much it is?
Around 20. No, 50,
200. Around 200 ml per second is the flow rate. Flow rate is most important judgment for the environment in which you are measuring the gradients, for the simple reason that even if you go to Gorlin's formula, they were using flow rate. They were using the flow rate. So that is why it is important to know. Now anything which is less than 200 ml or 250 they take it, but anything below 200 is a low flow setting. And it is much superior to the stroke volume indexed. So always look at the flow rate. So we know that the flow rate is low. And the flow rate is low because it was actually, we took it 250 just for the calculation, 285, so if the flow rate is going to be less than 200, and you have a stroke volume which is less, and so that means that 1 square centimeter wall area is during the low flow state. So already it is on borderline, probably you give a dobutamine, it will further increase, then probably I know that this is not a, and on low dose dobutamine, even if the stroke volume doesn't increase, the flow rate increases is good. Let it go over 200 and that aortic valve area is the perfect valve area, correct? So we know that this is a moderate AS, and let us look what is the mitral stenosis now. So the best...
And go to the mitral stenosis now.
Yeah, so best, pardon. It's called ejection time. And then when you take from beginning to the peak, it is called as the acceleration time. So when it accelerates late, that means it is a severe stenosis, correct?
So
And-
this have all got prognosticate importance.
Now let us look at the mitral wall orifice. If you have a biplane one, then it's very good because then you can put another one perfectly at the tip of these leaflets so that you get a short axis on this side. In a short axis, I think the mitral stenosis always measure first with planimetry.
Yeah.
Do not use anything else. And never use the pressure half time in especially this kind of middle-aged patients and also because
With
you know
LV
that
dysfunction and
it's
all
going
those
to be and in LV dysfunction because it depends upon the LV relaxation time. So never use it. So now let us do it. Okay. We know that this commissure is partially open. This commissure is this. Sometimes the calcium can create a horizontal horizontal signal. What is it called? See this calcium. Do you think that it is really like it's like horizontal like this? No, that is true, but still, do you think that this calcium is pressed and is made like a slab? Is it like that? No. This actually is called as the side lobe artifact. So any very echogenic structure looks horizontal line. Okay. So that is why never think that this is actually this is a virtual reality, that this calcium would be horizontal like this. A speck of calcium will always create the feathers on either side. Okay, it is called side lobe artifacts. Okay, and they generally go in a radial direction. They go in a radial direction. Okay, so this what you are seeing is horizontally like this is all the. Now anyway, now measure from inside. You measure from inside.
While
and
measuring,
you should always be before the P wave in a mid diastole. So this is perfect. This a mid diastole before P wave. Measure the mitral wall area.
It has to be zoomed. It is better to be zoomed before measurement.
Yeah, and
because the chance of error will be less.
And it should be a zoom. Yeah, it should be an. I'll still make it big, but and always acquire in zoom. You don't take it and then don't do the post-process zoom, because post-process zoom is all eyewash. You have to acquire it in a bigger this thing. See, because what happens is, again I am coming back to the real estate. This is the only real estate you have got. You have got only this many pixels available. So if you take a small area of the heart and put it into that entire real estate, you get much better resolution. And your most important is why echo is criticized is because of the restudy variability and inter-observer variability. That can reduce when you have this kind of a discipline of zooming, measuring, everything from spectral Doppler to the 2D measurements. If you have got this kind of a discipline among all your colleagues, you will not have that kind of variability.
Can you can measure. It will be severe, I think.
Now what you do is that, we were not going to use the pressure half time 100% in this patient. What is, now let us take the mitral wall, the spectral Doppler, and let us look at it.
Yeah, it's severe.
It is severe. And then let us look at the mitral spectral Doppler and let us see whether are we gaining any certain more information.
Yeah, spectral Doppler.
So, everything in the, let us put it there. You can see a reverse pizza here that tells you that it's very significant. Yeah, and then just
baseline down.
Take the baseline down. Baseline down and just increase the correct
scale, and let's have three.
A little bit.
Yeah,
correct.
This is going to be correct. Yeah. Now here, what? Stop it, and just let us take this. Now, in this particular Doppler envelope, you are seeing a very white line here, while there is very less signal here. So, what is it? That means most of the RBCs are moving at this velocity here. Okay. So, this is called as the modal velocity. That means modal is what mean and mode. No? Mode is what is the main weightage of the entire data. So, most of the RBCs are moving in this velocity spectrum. So always take the outer border of it. Don't take these spikes, which are the feathering artifact. So outer border of the modal velocity is something that you are going to take it. Now this gradient is very small, 6. Why it is small? Because this is also low flow, low gradient.
Yeah.
Isn't it? Okay, because the ejection is low, so the sucking is also low. The same thing. So this is also going to be less. So that's why it is just 4. Now look at the mitral wall velocity time integral, which is 46. Divide that by the LVOT video. When in absence of a significant MR and AR, what is going across the mitral wall is going to go across the LVOT, isn't it?
Yes.
Isn't it? Now, your LVOT video was 25. How much was it? 25?
25, 12.
LVOT VTI was
How was the
12,
LVOT
12 or
VTI?
something. 12. 12.
LVOT VTI, just look at this. Somewhere you have this LVOT. Yeah, look at the
12,
LVOT.
12.
12. then when you are looking at dVi, that is the Doppler velocity index, always numerator will be the proximal velocity, denominator will be the lateral velocity. So that means if you take the mitral VTI, which is 46, divided by the LVOT VTI, which is 12, in absence of significant MR and AR. Now we knew that it is the mild AR, mild MR, so we can, so what is the ratio? 4, almost.
Almost 4, huh?
Almost 4, okay. Anything going about 2 point, anything
Five.
going about 2 itself is abnormal.
2.5
Why
is
I'm
definitely.
saying 2 is abnormal?
Definitely.
Can you give an explanation, mathematical explanation, why anything about 2 is abnormal? Because here you had that luxury of measuring the annulus. Now suppose there was a prosthetic wall there. You
Exactly.
can't see the orifice on 2D. But then this is handy. Why this is handy? Because in that low flow state, water is going across going to LVOT. Now how much is generally the LVOT cross sectional area? See, generally if you take, you will most of the time find 20 millimeter LVOT. So your radius is around 1 and 3.14 into the velocity time integral. So generally you will have that the LVOT, that LVOT cross sectional area would be, if you take pi r square, will be around 3.5.
3.5.
Bro, 3.14 into 1 square, correct? Let us take 3.
3.
Okay. Now you know that the mitral flow, mitral velocity time integral, okay, the cardiac output across the mitral wall is what? The mitral wall VTI into mitral wall area. Now divided by LVOT cross-sectional area into LVOT VTI. Okay. Now suppose, now both should be the same, isn't it? Both should be the same. So if my VTI increases or decreases, proportionately the wall area should go down.
Yeah.
Correct. So that means if my ratio is 2, that means the mitral wall area has already halved.
Half of.
So when my LVOT area is 3 square centimeter, and if my ratio of VTI is 2, mitral VTI is twice the LVOT VTI, that is my mitral wall area is halved. That means already become 1.5.
1.5.
Okay, it's a simple logic about it. So when it is 4, then I know that it is now 1/4 of LVOT. The area is 1/4 of LVOT. Okay, so this is important in space of a bioprosthetic wall, metallic wall. Look at this DVI. Okay, that is a very simple way, and you are not taking anything. And Doppler is completely reliable.
In fact, in prosthetic valve, it has to be done. Otherwise, you can. It has to be done.
Yes, so that means what happens here is that you are not assuming anything, and low flow doesn't matter because the low flow is affecting the mitral and aortic wall the same way. Isn't it? So that is how it is. So now again also I know by another. So you have got internal correcting, internal quality checkups that you saw the area yourself. Then also you saw the DVI, you know that it's so high. You know now that this is significant stenosis. I don't have to worry now.
Anyway, this is the case of severe mitral stenosis. Now, how to quantify the MR in this patient, whether it is a mild or moderate?
Moderate. So
that is very important.
important.
think
So
That is very important in this case.
correct.
Zoom it up at the proximal.
So as we know that the MRs, now obviously what DVI we talked, if there was a significant MR, is completely out. We should not have. If you have got a significant regurgitation on either side, aorta or then you don't use DVI. Okay.
Yeah.
Now here, as I told you, always look at the origin of the jet. Correct.
That's been vena contracta.
Vena contracta. So you first vena contracta should always be seen in pilax. Why? Because vena contracta is a measurement, neck measurement, which is always good in the axial direction. Axial direction. So in axial direction, vena contracta will come only in pilax view. Okay. And while you are doing a vena contracta, also you bring down the Nyquist limit so that then it really becomes much sharper. Okay.
Decrease the spectrum of color.
Yeah, just put it,
are putting
try
it
to get an MR there.
MR.
MR, yeah. We are not going at the AR, we are looking at the MR.
Yeah. Let's do MR.
MR.
MR, only
Just
MR.
look at the neck of the MR because the measurement that direction would be better in the axial direction. No. 4-chamber you should not do because that is horizontal. So you do it always MR, this thing.
Decrease the spectrum of
Yes,
color.
now zoom this and bring down the Nyquist limit as if you are looking at the pizza. Just bring it down so that you will see the, now stop this. And now you measure this vena contracta.
You can zoom. You can acquire while zooming.
No, I think the next envelope was better.
Quite good.
Yeah, this one. And I will take the narrowest point of it. Narrowest point there. This one. Below this. Yeah. See,
can
vena
remove
contracta, remember, vena contracta will be below the anatomical orifice.
Yeah.
Okay, below the anatomical orifice. So I know my leaflet is here. So this is where is the vena contracta. Because a jet going through a narrow area continues to narrow for some time. So it should always be below the jet. So this is hardly anything. 3 millimeter is minuscule. Now I will look at the pizza in a long axis view. Okay. Now pizza at when I'm putting it, this Nyquist limit at around say 40 and less.
Yeah.
Let us look at 40 and less. If it is less than 6 millimeter, I'm sure it is not important. And why? Because at 40, what you have to do is that you have to just square the pizza radius and divide it by 2 to get a ERO. Okay. To only to 40, yeah, 30, 70, it doesn't matter. But take a
spectrum.
5 chamber. 4 chamber.
You're looking at mitral
4
valve.
chamber,
Go to the
yeah.
fourth chamber.
Pizza should always be in 4 chamber. And then if you keep the Nyquist limit at 40, then it's very simple. R square by 2 is your ERO. Okay.
Remember, you always decrease the Nyquist limit towards the flow. So in MR, the flow is going down. So the Nyquist should go down here 40. In AR, it is going up. So Nyquist limit should go up there.
Exactly.
That's the way.
So just go. So always the Nyquist, this baseline should go in the direction of the jet. So that is why in T it will be different. It will be up. Yeah,
very
that's
fine.
fairly correct. And what you have to do now, just zoom this. This is a very good important. Just zoom this. Can you do the post-process zoom also? Doesn't matter.
Post-process zoom. Use
Post-process zoom also is okay for me. Zoom.
Frame was very
Okay.
Yeah, zoom. I want extreme zooming.
It
Just
is not.
zoom.
That is the maximum zoom in this machine.
What
No,
is
how
the
can
maximum
that
zoom
be?
in this
It's
machine?
T9.
T9.
I don't know.
But anyway, now what you do is that, how do you know which is the neck? Always look at the lateral side. If you see a black line going horizontally, see, because when the flow is going towards the, say, like the sink has a hole and the flow is going, the flow which is perfectly perpendicular to the ultrasound beam will not be registered and it will look like a black line. And you know that is the neck. Okay, so if you had zoomed it, you can see that this is a black line.
Yeah,
Okay,
yeah,
here.
yeah.
So I will take this as my neck, and from here I will measure the
Pizza radius.
pizza radius from blue to yellow. So that means it is wrapping around to the yellow, that side. Correct?
Measure it
Pardon?
a little below.
Yeah. Correct. That's the one. Yeah. And you have to start from here because
Bah,
the
fine,
horizontal
fine,
black
fine.
line is here. So how much it is? 4
0.4.
millimeter. So 4 millimeter square is 16 divided by 2, 8 millimeter square. 8 millimeter square is a mild means grade 1 MR, correct? So we know that this is provided your Nyquist limit is at around 40.
So this is not a significant mitral
This is
regurgitation.
not at all a
It's a mild.
Significant mitral
So
regurgitation.
always look at the origin of the jet for the severity. Don't look at how far it is going. This can still be, if this origin was not there, if a severe jet which is going is not in this imaging field can look mild also.
But you know, I have a simple thought that this is LV dysfunction, systolic dysfunction. So do you think, still think this piece of 4 calculation of mild MR is good, or we should report it as moderate?
No, I would still call it mild because
Or
then you
how
will have
much
to
was
take
Vena
the peak
contractor?
velocity of the
PISA
MR.
4 means you have to calculate then otherwise.
No, what was the Vena contract? I missed it.
Vena contact is
3
3.
millimeter.
3 means
was
mild.
mild.
3
It
means
is
mild.
So the point is, in presence of
See-
LV systolic dysfunction, Vena contract is
Yeah,
Vena
and this
contractor-
R square by 2 actually assumes that the MR jet is 5 meters. Which, as he said, LV dysfunction, the MR jet may not be 5 meters.
Dr. Santanu, Vena contracta more than 7 is severe, no doubt. Less than 3 is mild, no doubt.
Correct.
In between 3 to 7, there is no clear demarcation whether it is a mild to moderate or moderate to severe. That is no clear
But
cut
just looking
demarcation.
at this puny pizza,
It
I
looks
know that
like
is
mild. It looks like mild.
Now,
but
can I go to the little bit of the tricuspid regurgitation, how to quantify the tricuspid a little bit, so that the valve will be complete at this
I
moment.
think he
And if we
also
have a
has,
PR also,
he has
can I get it?
tricuspid
also?
valve thickness also. I have a feeling. I don't know.
Yeah, so TR you should always do the peak velocity, and unless you get a very good envelope, don't measure it.
If he has
Now,
tricuspid
now
stenosis.
just remove the color. Yeah.
How to
If
quantify?
the leaflets are not co-opting, this is severe TR.
Is it a moderate or severe tear?
It is severe means 100% severe, no doubt about it. And that too by just looking at the leaflet. So when you see non-cooptation of leaflets or a flail leaflet, it is severe. whatever may be your color Doppler. I will give a hood
Because
to the
vena
color
contracta
Doppler.
is definitely more than
They are
that.
not even closing. So
Yeah.
just imagine that this you are seeing in 2 dimension. In 3 dimension, it will be a big hole. Okay, so you know that this is severe TR. And this patient need an annuloplasty, whatever may be the annuloplasty. Now just measure the TR. So even
Otherwise,
if you
postoperatively you
see,
will
you
be-
give diuretic, it will be grade 1, grade 2 TR. You give him with saline 500 cc, it will be a severe TR. But what doesn't change is the
Vena contracta.
non-cooptation. That remodeling tells you, annular remodeling, that this is going to be a severe TR. And it's never going to change even if you fix up this mitral wall. Even if you bring down the pH, this TR is going to remain voluminous and TR begets more TR. Okay? So, this...
Nee, Nitin, what is important? The vena contracta or the tricuspid annulus?
Tricuspid annulus.
Tricuspid annulus. The single most important is the tricuspid annulus. That you have to remember. In case of tricuspid valve, the tricuspid annulus is the important things. Because this is very important nowadays. So this is there. And any PR is there? So we can have an info.
Get the TR envelope. TR envelope you take it.
Yeah, tear envelope.
And we'll always also try to see for tricuspid stenosis if it are.
Yeah.
I don't know, because are they thickened tricuspid valve?
Yeah, they are thickened.
Yeah.
And there is a forward
There is a
gradient
forward
also.
gradient also. Yeah.
Unless you get such a envelope, do not measure the TR. If you just get a small one, then look, don't take the feathers. Don't take the feathers, you take the outer border of
this one is
the
okay.
modal velocity.
How much is?
And this mistake is actually much more pronounced in aortic stenosis. You get these kind of feathers like this, okay, and people measure it here, which is absolutely wrong.
Trace it.
It should always be at the highest, the modal velocity outer border. Never take this feather here.
You take direct trace.
Yeah, I think you may not take a trace also,
Just
but
take the
peak
peak
velocity
one,
should be
peak.
sufficient. Yeah,
Peak velocity is
peak velocity should be sufficient.
plus 10 or plus 15. It was about 2.1 and IVC was something like that, 45, 50.
No, so it's very important in this case, particularly the assessment of the RV. Because see,
It is a combination of both,
Yeah.
I think. It is a combination of
Yeah,
both.
both. But as you rightly say that there is a tricuspidal pathology, so that is why this TR is not going to regress, even after correction of pH.
nah, Nitin, is it because of the only
What is-
tricuspid annulus enlargement or there is an RV dysfunction also? That is a very important thing.
I think here even the tricuspidal has got a rheumatic affection.
Yeah,
Yeah.
you can assess
So
the
there is a
forward
primary
flow.
pathology there. So that is why I said that before putting a color Doppler, always look at the leaflet
You
more
can trace the
carefully.
tricuspid, you can trace it, how much is the gradient across the tricuspid valve.
Yeah.
Forward
we
flow also. So I think which is the best view to measure the annulus was the question.
Again the RV focused
flow
view
focused
and
view and
try to adjust till you see the maximum size of the
I think I
tricuspid
do it
annulus.
RV focused and subcostal also. If you
Yeah,
get a
and
good-
keep on adjusting till you get the largest diameter.
So
I
peak
think
by-
it has to be kept in the different chambers and get an average. Otherwise, tricuspid annulus, what you were telling, sometimes it can be get from the subcostal view is properly well.
Yeah.
But you may not get the RV focus view in each and every cases
Correct.
properly.
So I think the peak by mean is around 8 by 5, 8 by 4.
So there is a 4 gradient is across the tricuspid valve, there is definite affection of the tricuspid valve is there.
And partly the gradient is explained by a voluminous TR also. It's a very voluminous TR, and that means there is a primary tricuspidal pathology definitely.
You can do this tricuspid valve in the free wall, RV free wall strain or the TAPC. How much is the TAPC in
Yeah,
this
we
case?
can do that.
TAPC or the free wall. Because we have another 5 minutes time, then we'll go to the next. Cardiomyopathy again? Okay, HOCM. We'll go to the HOCM then. That's a very interesting, will be. Yesterday, a lot of discussion about the HOCM and all these things. Yeah, definitely reduced.
So in
TAPC is
spite of
different.
the RV dysfunction, the TR is almost 35, 45.
It's not actually 17 because your baseline in this is little bit. You can zoom it again in. No, you are
Yeah,
going
it is
this
less.
is from take
It's
this from
1.5.
this to this area to this area, from this to this. This is the area and go to this maximum. That's 10. It will
Yes,
be 10,
RV
10, 12.
dysfunction. Systolic dysfunction is there. You can
And
al-
what is the, you can do the free walls GLS? From the LV model you can take, and take the good view, focus view of the RV. RV focus view. Okay, you can take the, how much is the? Yeah, it is below 10. Obviously below 10. So there is some RV dysfunction. And
Yes.
what is your important in this space? Even if you do the tricuspid annuloplasty, this RV will improve.
I think no. I think first, I think it will be good that this rate control is better, okay, and he is on optimal medical therapy for heart failure also, because I think there is a primary myopathic disease in this patient because of probably tachycardiomyopathy or something like that. Because the valvular disease doesn't explain biventricular dysfunction. What explains is probably a very chronic AFib.
Yeah, because many of the patient, even after mitral valve surgery or the mitral valve replacement and the annuloplasty, tricuspid annuloplasty, these patient fails to symptomatically improve. So it is better to counseling this patient if you have a RV dysfunction, that you may not get the required money, whatever expected.
Yeah, that is good.
No, that's quite fair.
It will give you RV free wall separately.
Anyway, forget about this septum. Only thing the free wall is best.
Yeah, it will give you both RV free wall.
Yeah,
also will give you.
definitely less.
Yeah.
It's already less.
It's something like 9.
Yeah, free wall strain is
21,
-6.
7, -7.
So don't go for the global, go for only free wall strain. Okay.
Means
Anything
septum is
below
a little
20
bit
is
better.
abnormal.
Yeah, now we change the patient. We'll go to the cardiomyopathy next again. Hypertrophic cardiomyopathy, okay?
Free fall still. Only free fall still.
HOCM patient you have? Sulogna? Okay.
You have to do the border. Yes. Yeah. I think if the LV dysfunction is present in isolated MS in the absence of AF, they generally recover. But if the cardiomyopathy, if there is some rhythm problem, then it becomes very difficult. Yeah.
And I think the age also matters.
Once the RV goes, it is very difficult to come back.
LV is not a problem. Even if mild LV dysfunction can improve even after the mitral valve surgery. Nothing, I am right?
RV doesn't come back.
But RV is a very important problem in this particular population.
Any questions till now?
Still about my valvular heart disease. Any question about the valvular heart disease? Any query?
Yeah.
Yeah, on the mic. We are not able to hear.
How frequently we are doing right ventricular annuloplasty?
For the right ventricular tricuspid valve annuloplasty.
The answer is it should be always be done.
Always.
Always.
They provided it is more than
It is
40
there.
millimeter.
If it is indicated.
Yeah, if
should
it
be
is
done.
significant,
You should.
So, see, recently there is a big article in JACE and everything in about tricuspid regurgitation, and there is a lot of focus has come out to the right side, and they are telling that tricuspid valve assessment should always include tricuspid annular assessment in patients of all valves, in patients of cardiomyopathy, because if you don't identify, if you don't do surgical treatment, even and just leave a mild TR, it is going to progress. So what he has been trying to tell is tricuspid annulus assessment is mandatory. Always. And you have to tell the surgeon, if indicated, do an annuloplasty at that time. Because redo surgery is very difficult.
And interestingly, when you are measuring it 40 millimeters, okay, actually the surgeon measures it's more than 7.5 millimeter diameter. because he actually gets septum to lateral wall dimensions, which we never get actually. So actually when we measure it at around 4 centimeters, surgeon will be measuring it at 7 or 7.5 centimeters. I think probably in a cardiac CT, it is much better. Cardiac CT, it is the perfect way to get the tricuspid annulus. Yeah. Not on the MRI. Yeah. You don't get that three-dimensional data in MRI.
Thank you, sir.
The annuloplasty ring is around 3.8. What sizes do they get? Because they do you 38 and above, they start putting it.
So we are at the hypertrophic cardiomyopathy. Yeah. So one, huh? It's a very interesting thing, because as we know that we have to look at the risk factors of this particular patient. So what first I would see, just looking at it, we know that there is a, there is a hypertrophy and there is a systolic anterior motion, correct? So now what we would advise first is to, you want to just first look at this SAM on the M mode. Let us put the SAM.
What I do whenever we start getting a basal septum hypertrophy, I generally try to increase the spectrum, the width of this maximum. Try to get the type of LV. This is we are getting a good LV. Now let's get a SAM.
So let us put the M mode there. You can, yeah. And M mode, as we see in systole, see this is the early diastolic opening, atrial kick opening, and then you can see in systole, the whole closed leaflets are actually touching the septum. So this is the systolic anterior motion. You can put a color Doppler and you can get a color M mode also. Put a color Doppler there.
You can have a turbulence.
Color Doppler, and then let us put the M mode there. Let us put the M mode. And see, beautifully you can see that this is the early diastolic mitral wall opening, aortic wall opening, and this is the SAM. The closed leaflet is approaching the septum and there's a lot of turbulence. So you know that there is a dynamic obstruction. Now the first thing, as we know that the first two factors clinically are whether his first degree relative has a sudden cardiac death, or he has an unexplained syncope, or he has a resuscitated cardiac arrest. These are the most important things, which are history, which is not echo. Now we will go for the maximum thickness of the any focal maximal thickness. Now, do you want to do that thickness measurement in the long axis or in the short axis? Better do it in short axis, because in long axis, even if you are slightly tilted, there will be a problem. So what I would suggest is that you scan from the base, that means mitral wall to the apex, and just store all of them. Store all of them. And then measure in mid diastole, correct? So yeah, store this first, store this. Yeah, then next you store at the papillary muscle, store at the apex, okay, store. Now just show me the images, stored ones. Then how do you, no one knows how exactly to take the thickness. So generally what you can stop it in mid diastole, stop this in mid diastole, yeah. Now what generally do you do, just this is the cavity, just take a midpoint of that cavity, and from that midpoint of the cavity, just go radially, correct? So what you do is that just come to the midpoint so that you know that this is a part of the radius. Just come to the midpoint. Middle. Just come to the center of the LV cavity, center of the LV cavity. Come to the center of the LV cavity. From there, just go to the epicardium. Yeah, you know that this is the radius, and on this radius, you now measure the thickness, so that you don't measure it in the oblique direction, correct? So here again measure it, and never take any muscle bundle which is on the RVOT side, correct? So this is your radius, and on this, these are your radii. On that radius, you measure endocardium to epicardium, okay? This is your radius, forget it about. Any place where you are thinking that this is thick. Actually, I'm thinking this is thick. So just put a radius there and then take endocardium to epicardium. This one is actually having a radius. Just take this radius. This I think is much, because here you don't know how to go here. Take a midpoint, and just go to the epicardium. You know that that is a radius. Yeah, just go to the epicardium, anywhere where it is maximum. And now you measure from endo to epi and look at the thickness, okay? Let us look at the thickness, how much it is. 32, my God. So,
more than
so your focal thickness can be anything. Anything 30 millimeter and above is a very thin. And as I told you, the variability is 5 millimeters. So let us go at other places.
Maximum thickness from any point?
Any point.
Now,
Any
you have
point.
to mention the maximum thickness.
Magnus.
So you have to measure each and every point, then you have to give the maximum thickness.
So go visually, scan from base to apex and take the maximum, and many times the maximum thickness may be on the anterolateral wall or apical inferior wall, anywhere.
Anywhere.
We are all focused to the basal septum, which should not happen. And then don't go horizontally. If I had a measure like this, I may get a very extensive one. So go in the radial direction. Always go in the radial direction, okay? So let us go to the other view, and let us see what.
More than 2.5 is bad.
Yeah, so the cutoff for this is 30 millimeters, but as I told you that 5 millimeters is your inter-observer variability. So when it crosses 25, you may be still 30, na? So that is why anything going above, here it is already 30. Just take just here I think this looks more thicker, so I'll put a radius there and measure from endo to AP. Yeah, endo to AP, you just measure from endo to AP. No, this is not something guideline directed that you measure in the radial direction, but you should have some standardization. Na? So that is why you do it. And I think this is much more reproducible rather than doing anything as you want. And should be perpendicular. Should be perpendicular, correct. 30. This is a pretty good way, I think. Yeah, so there is actually, no one has put in the literature how to measure. So what they did in the European Society of Cardiology conference, that the very excellent centers of imaging, all those professors, they called to one booth and gave them the paired images of echo and MRIs without telling them whether it is the same patient or the same patient. They give two images telling that these are two different patients and asked them to measure. And among all those experts, they saw the variability was 5 millimeter. So that means no one knows exactly how to measure. So let us have some standardization among ourselves. Let us go radially, which I think is correct.
The 5 millimeter variability will be there.
Yeah, but the 5 is too high.
Too high.
See, that means someone 25 is already 30. That is very bad. Na? So that let us have that, we at least measure that way. Let us look at that way. So you get a perfect round and measure the radial directions, correct? So that I think here it also looks quite good. This I think looks quite big. This looks quite big. So anyway, it can be any focal point. So that is one point. Then the next point on the HCM. HCM looks very good, but we have to look at the prognostic factors is to look for an apical aneurysm. So let us take a 4-chamber view. And in 4-chamber view, keep on tilting, going up and down to see for an aneurysm. Because your aneurysm you can miss very easily here. So just tilt, go up. Now this patient doesn't have mid-cavity obstruction, so very unlikely he will develop an aneurysm. Someone who has got a very hypertrophied mid-segment and you get a color turbulence here, always look for an aneurysm, okay? Now here I am not finding any aneurysm, but that is another very important prognostic feature which unless you look for it, you will miss it, okay? So I don't think we are having it. I will check that also in the short axis views and all the 3 long axis view. 2-chamber generally, because 2-chamber generally you can see it much better. Go to 2-chamber also.
I think there is some aneurysmal tendencies there.
No, I mean, you have to have an obstruction.
In the mid-cavity.
Yeah, there are,
But
what
I
are the
think-
pointers actually that gives you a suspicion that
you have to put a
there
color.
might be some aneurysm?
You have
Yeah,
to put
so
a
generally
color.
if you put a color Doppler
and
here, if you have
turbulence.
turbulence here.
Can you
then
put a
we
color in mid cavity?
And see, generally that's why the
just
contrast
mid-cavity,
is so
go up,
important to
up.
look for. So
Nitin,
generally,
there is a suggestion. One is that doctor, everybody was telling about that if there is a mid-cavity obstruction, there is a definite chance of the apical aneurysm is there. And another is the putting a Doppler, getting a Nakamura sign.
Nakamura say you can get the mid cavity. No, what is more important is that even apical HCM, pure apical HCMs can also develop aneurysm.
Yeah, that is very
Because
important.
that we can miss very easily because they are not mid cavity obstructions. Apical systolic cavity obliteration. But slowly they start developing the apical aneurysm. So there you have to be very careful. Here there is no mid cavity or apical obstruction, so I will not much worry. But what I am trying to tell you is in all HCM patients look for that. So that is the second one which was very important. What is the third important, which is the lower down in the hierarchy of risk, is LA volume. Because we are all the time harping on VT, VF, VT, but many of them come with a cardioembolic stroke because of an paroxysmal AFib. So look at the LA volume in these patients. That LA volume tell you whether the fibrosis has extended in the myocardium, so the LA is increased. So they go into HEPPEPs. And next more important is that the chances of developing atrial fibrillation. So that is why LA volume, it is lower down in the hierarchy, but it is important for knowing the AFibs. That are not going to get corrected by your ICD, but that is important. So that is LA volume. And lastly, what is more important from prognostic point of view in this patient? Last two things. One which is very important, higher in the hierarchy. EF, 50% or less. So EF measurement in this by biplane is more important. So just by looking at the hyper is not important. So focal hypertrophy, ejection fraction, apical aneurysm, and lastly the LA volume, which is down in the list, okay, for your risk stratification in these patients, okay. And then what we would look at is, see, that is why the inferior septum was much bigger, okay. The LA, I don't think is very big, is not very big.
Not very big.
But
Not very
I would like to add two more things.
Yeah, and then dynamic LVOTO, that is also lower in the hierarchy, but it is one of the important. So what we will do is that we will do his resting echo. Then two things you can do it. If you ask all these patients very carefully, they tell you that when they are full stomach, they feel very uncomfortable. Because postprandial, when there is a splanchnic vasodilatation, they get a lot of LVOT gradient. So ask these patients to come for echo with a full stomach. That's the best way to do it. Or you do Valsalva. So ask him to do Valsalva.
Even after Valsalva, how much should be the minimum, how much should be the significant, we call it?
So see, when your resting gradient is above 30, you really don't need Valsalva. When it is below 30, and if you do Valsalva and it goes above 50, it is a very significant. Significant gradient.
That is very important to remember.
And I always prefer to do Valsalva and the gradient in 3-chamber view. Why? Because you don't contaminate your CW with the MR. These patients also have MR. Invariably with Valsalva, the MR will also increase. And if your CW catches MR in 4-chamber, you will get a very, very high gradient, 5 meters. So that is why best is in 3-chamber, they separate. Because generally the MR goes away from the AML and the LVOT is in this direction. So always do it in 3-chamber so that you will not mistake it, correct? And here is the, here already the gradient is 4. This is with Valsalva.
Severe gradient.
So severe. So this is another.
Resting gradient is more than 65.
Yeah. So this is another important risk factor, but it is lower down in the hierarchy. So we have covered everything in the hierarchy. But before that, I would like you to go and do a good GLS on this patient. Always do good GLS on this patient, because if you have got an apical sparing, think that this is an HCM mimicker. Don't go just by asymmetry. Rather, ATTR amyloids have a lot of asymmetry. So having an asymmetry doesn't mean it is a sarcomeric HCM. Okay? So that is one important aspect. And even having a dynamic LVOTO also doesn't tell you that this is definitely a phenotype of a sarcomeric HCM. So that is why always do a very good let us do a good this thing. So what would you find in a GLS, in an HCM? What will happen to the areas which are hypertrophied? Will they have a very high strain, low strain, intermediate strain, strain variability? Tell me what will going to happen. Anyone?
Nitin, another question.
Yeah.
If a patient of the HOCM has aortic valve disease,
Yeah.
then how can you comment about the hypertrophy?
I think let's go one by one.
Yeah, no, that's a very important question. Or hypertension or aortic stenosis, then how are you going to
No, so they coexist. One is hypertrophy coexists with amyloid, hypertrophy can coexist with AS, hypertrophy coexists with hypertension. That is
Amyloid is a different issue.
So
there is a difference.
these are all rule of 10% are. So I think what he asked was, first is we can solve all these things. First thing was, what will happen to the strains in this
this particular,
patient?
yeah, and then we'll go to the other afterload things
So
that can reduce, that can cause it, okay?
So the strains will be down. Global longitudinal strains will be down, even if the ejection
So,
fraction
but
is
what happens at the hypertrophied area? Will they look dark red? Will they look less red? Will they look blue? Will they look what?
Yeah, comment. You can comment.
Any comment.
Are you understanding the question?
See, because this hypertrophy is pathological hypertrophy. There is a muscle bundle disarray and interstitial fibrosis. So what happens is actually there is no good deformation. Rather, there can be lengthening at certain places in the hypertrophied area. Rather, hypertrophied area should have very good deformation, isn't it? Because if it is suppose athlete or it is because of even hypertension, they should have good deformation. So what you get is a very variegated pattern with areas of blue in between, because there are so many areas of fibrosis. So in a hypertrophied zone, getting a variegated areas of strain is a very pathognomonic of HCM. Unlike in the amyloid, the basal strains go, middle strains go, and the apical strains remain, correct? Because of the deposition. So you get that apical cherry on top, correct? Secondly, if there is an apical aneurysm, then the apex looks blue rather than red, telling you that there is an apical aneurysm. Okay, so that is how the strain maps can help you. Okay, and as we came back to Dr. Day's question, whether what is aortic stenosis and hypertrophy, generally this variegated appearance won't be there on the GLS map. Now suppose someone is a ACE and he develops a significant hypertrophy. He will develop some amount of interstitial fibrosis, but he doesn't have muscle bundle disarray and he doesn't have replacement fibrosis. So generally that kind of the blue-red disarray that you see in the septum, you won't have in those. There the GLS will also go down, but that variegated appearance on the map will not be there. So that qualitative is one of it.
In this
But
patient, it was
one
minus
important thing is
3.5.
that while measuring
Can you show
the thickness of the myocardium,
Is also important.
very important.
Very important.
So that
So this
is
is a
very difficult.
very, very valid point, because as we discussed yesterday, that even an athlete of Afro-Caribbean origin who develop very hypertrophy, they don't go above, even Olympic grade ones don't go below 15 millimeters. And Indian athletes very unlikely will go above 13 millimeters. Okay, anything going above 13 millimeters or
pathologic.
15 millimeters if you are getting African patients, it is very unlikely that this is a hypertrophy of training. Okay, it is definitely some sarcomeric thing, correct? That is one thing. Then another important feature is just look at these leaflets. And elongated AML and PML is actually a very important phenotypic feature of a sarcomeric HCM, which is not seen in any other causes of hypertrophy.
So 10% of patients of HCM can have mitral valve apparatus pathology. And it should be noted so that you tell it to the surgeon, because at the time of surgery, if it is neglected, then it can have problems.
So very long mitral leaflets again tell you. What is the third point that can tell you this is phenotypic? This is a phenotype of a sarcomeric HCM is looking at crypts. If you have certain crypts, and that is especially when you use a LV opacification contrast, you can make out, or MRI shows it because they already have a blood which looks white. So if you have got something going into the crypts, these crypts don't happen in other type of hypertrophy, and they are generally related to the HCM. So certain features like this PML, have you ever seen such a long PML? Yeah. See, because this is a 3-chamber almost. Have you seen such a long PML? Now start observing the PML in the normal people. If you get such a long AMLs and PMLs, even in a mildly hypertrophied heart, think that he probably is developing a sarcomeric HCM. And why I'm telling you this? Because HCM doesn't come out of the blue. The same patient with the same genotype, in the same family, the phenotype can come up later part of the life. So every decade, people carrying the heavy myosin genotypes, every year, 10 to 20% of them will be phenotypically HCMs. So that means when you have an index case in his family, you will be much more suspicious. Then in that family member, if someone is crossing 11 millimeters, you will know that he is probably carrying the genotype. If he has got a elongated AMLs, they don't develop later. Then elongated EMLs and PMLs in a first degree relative of an HCM patient, you will be worried because he is carrying that. Because he may become after a few decades, isn't it? So that is very important. And then the scripts. Yeah.
May I make just a point? You are all talking about the mitral valve pathology in HCM.
Yeah.
Recently, I came across a case report. There, not the AML, but the PML was the cause of subalveolar obstruction.
Correct. Yeah, there's a case reported there.
Yeah.
So
we have to look for unusual things.
Absolutely.
Including the cardi. There may be caudal pathology as well.
Right. So in HCM,
yeah, I think that's a very, very valid point. Yeah, because this is very important that this point is raised, is the subvalvular apparatus of this mitral. See, what has happened is, as a resident, we are always taught that there is a Venturi effect, but that is all nonsense. Okay, that is all nonsense. What actually happens is that the subvalvular, the papillary muscles are rotated in an anti-clockwise direction. Okay, so generally what happens is that your LV inflow and outflow are perfectly different in the LV cavity. So nothing comes in the way. The moment your papillary muscles rotate, your commissures also have to rotate in the mitral wall because each papillary muscle gives supply to that particular contralateral commissure. So if the leaflets are also going to rotate this way, then when the systole starts, now the whole apparatus, PML and AML, is going to get pushed towards the LVOT. And that is how you create the obstruction. In other way round, the commissures are like this, and the leaflets close, LVOT remains open.
Exactly.
Yeah, while here, now the commissures are rotated like this because your papillary muscles comes anteriorly. When the LV starts contracting, you are pushing like a wind sail, the PML and AML towards the LVOT. So there's nothing like Ventura, all humbug. It is this pathology. And why it was important is the surgeons actually were more intelligent than us. They said that only doing a septal resection surgery was not improving, but when they started dissecting the papillary muscle anteriorly and making it lateral, actually there was a significant reduction in the gradient. So, if you look at the American centers, because in USA you have to send to the center of excellence for the septal reduction surgery. You can't send to any other surgeon because otherwise you will get sued. So there are only few centers of excellence like say Mayo or New York, there are 2 centers. All those surgeons, almost 70% of their septal reduction surgeries, they also disconnect the papillary muscle and rotate it down. Now in this patient, let us see how is the papillary muscle. Just show me the short axis of this patient.
Yeah, so you know, you can
In
show
the
the short
meantime,
axis.
you
So
can tell about the mid-cavity obstruction with the apical aneurysm, the clear display of that.
Excellent. That is,
So HCM follows the rule of 8 to 10%. So you can have
now
mitral valve.
here itself it is perfectly fine. See, you can see that this papillary muscle is rotated slightly anti-clockwise. Generally, you will have a papillary muscle here and one papillary muscle here. This is already rotated. Now, if your now commissures get oriented in this direction, though this doesn't look extreme, some of them have got somewhere here. If your commissures get oriented in this direction, remember the AML is like this, PML is like this. When the LV starts contracting, both are going to like a sail of a ship, are going to get pushed and obstruct the outflow.
And many times you
Which should never happen because the inflow should be like this and outflow is here. So, you know, when this starts closing, your outflow is still open, isn't it? So this rotation is also very important, okay?
Many times you have accessory papillary muscles also. They have all this kind of
Sometimes the papillary muscle directly goes into the AML, okay? That there is no chordae. It just directly goes into AML. So every time the MR is not because of the SAM. It can be because of the mitral pathology, which he was saying 10% of it. Yeah.
Also try to look at the RV outflow tract obstruction because many times HCM patients you are only focusing on LV, but they can also have RV obstruction. We tried to look at it. It was not there. And
so did we get the GLS? Yeah, just show me the GLS map.
5 point something.
No, what is important is look at the qualitatively. Just go to the GLS map. Yeah. Now, if you know that the septum was the most hypertrophied thing, and it has got some areas of blue, okay, and some areas of very low strain here. Okay, this can happen, that means this hypertrophy is pathological. This is because of the disarray, because why some part of the septum is actually lengthening, because those areas are the interstitial fibrosis, replacement fibrosis, which are actually lengthening. So this is very, important about it, and that the hypertrophied areas show it. And generally.
But you know, the interesting part is not in this case. If this kind of picture with slightly brighter apical thing goes, so that even
in favor of amyloidosis, you are telling.
Coexisting amyloid.
In amyloidosis.
Yeah, this
well,
is Dr. Jamil Tajik's paper.
I'll show you a case in the evening that then you can your answer will be
correct.
But I think this is a nice case.
To give your answer, then that time you will be able to answer this thing.
So
Anyway, this is finished. Any question about the hypertrophic cardiomyopathy from the audience? Then we'll go to the next ischemic heart disease.
You also have to tell the filling pressures and E by E prime. Yeah, please. Right. No need. Why do you
No,
want
I
to
think they got it after Valsava probably.
The resting was 70, madam? How much was the resting gradient? It was 70. 74. It was, I mean, there is, you can always do anything, but there is no. Yeah, so Dr. Deepankar Datta is telling that there is a recommendation about HCM in June JACE. I think it has come, correct. Another thing is all patients of HCM should be screened for sleep apnea study because sleep apnea also coexists. And sleep apnea patients should be screened for HCM.
So the variegated appearance in
There's
GLS.
a question there, then we'll take it.
Sir, as sir told that we get a variegated appearance in GLS in patients with HCM. So any other conditions
In
like
any
mixed pathology?
cardiomyopathy, it need not be, see, what he's trying to tell is when there is a problem in the muscle because of sarcomic problem, inherited problem, you get all dysarray. But in other patients, in aortic, there will not be so much of dysarray. Am I correct?
Yeah. Yeah, see, like in an ischemic heart also you may get. But
You
the
may get it at a
problem is
later
that
stage.
there is no hypertrophy. Here in presence of an hypertrophy you are getting it. That tells you that this is purely pathological. There is no deformation actually, there is a lengthening in areas.
So one
this
part,
has to be
is contracting, the other part is elongating. It's all.
So if you are just given this particular one, can be anything. This map in presence of your 2D echo image of hypertrophy, then it is, you know that this is HCM. Not just given an GLS map and whether it is HCM, it's not so. Because even some dilated cardiomyopathy, you may get something like this.
Okay, sir.
And just you were mentioning about the contrast. After the era of this strain imaging, do you ever do a contrast study for diagnostic purpose? So for typical aneurysm, you have suspicions. Do you do a contrast study?
Only for picking up an LV apical aneurysm,
for-
when we see an apical HCM or mid cavity obstruction, then only we do the contrast to look for the aneurysm.
Whenever in doubt, if it is, that patient it was very clear. Any history, anything? It is a patient, ischemic heart disease, something.
Correct.
Elvis
So
is-
in the last
what-
case, excuse
what
me,
we
sir.
would do is
Yeah,
that
we have a question.
So in the last case, that means we won't get any incremental things in MRI basically.
I
So
don't
this-
think.
we
Not
don't need to
required.
do that.
Definitely not.
Yes, sir.
Definitely not. Because already you have measured it. Thickness is 30. ICD decision is done for it. Now let us look at the regional wall. So the thing is, in the regional wall motion abnormality also you have to have some very perfect discipline. First is that you should have, let us take all the views. This is the basal short axis view. Just take a basal short axis view, store that. Okay, take a mid cavity view at the papillary muscle, yeah, and store that. Take a apical view, and in each view, see that you are seeing the endocardium and epicardium. If you are not seeing two consecutive segments with endocardium, you have to use contrast, okay? So when you don't see endocardium, don't take that view. Let us go for a 4-chamber view, which is the first long axis view. Good 4-chamber. I just want LV now. We are not interested in LA. So reduce the depth, take only LV in the center, and you should see the endocardium perfectly well. Store it, store that. Take a 2-chamber view, store that. Yeah, take a long axis view and store that. Take a long axis view and store that. Now, what we will do is that always describe the regional wall motion as per the 16 segments and not the way you want it, correct? 16 segments. So when we are in 4-chamber view, we know that these are the basal segments, these are the mid segments, and these are the apical segments, okay? So when you are describing a lateral wall, you will be calling, say, the middle and basal, or middle and apical lateral wall, or we are describing this is an inferior septum. So the basal inferior septum, mid inferior septum, apical inferior septum, okay? Second thing is that you know that only in the 4-chamber, now this is very basic for the beginners, that only 4-chamber that you have got all the 3 coronary territories supply. So your apical segments are with LAD here, your mid and basal inferior septum is your PDA perforators, and your mid and basal lateral wall comes from your obtuse marginals, correct? This is the only view where you are getting. Then, how to look for a regional wall, this I always teach, and many times you must have heard from me, is that put a stationary object there. So you have got these measurement calipers, you can put it there. Once you put it there, look for the regional wall segment by segment, than looking at the overall LV. This is very important but very simple thing. Look at one basal point at a time. Now just take just take one pointer here, okay? Just one pointer, your measurement pointer or something, you can just put it there. okay, and then look at segment by segment, and so you look at one segment at a time, one segment at a time, one segment at a time, and then you appreciate it much better. What do you appreciate when you are looking at one segment? So looking one segment at a time in any view is important. In that segment, look at the endocardial excursion and systolic thickening both. Very important, okay? Generally in a normal kinesis, there will be 50% systolic thickening. When the systolic thickening goes below 20%, you don't appreciate it, correct? So in this case, this is the two chamber. In two chamber, you know that this is the anterior wall. So this entire thing will be supplied by the diagonals, okay? And this is the inferior wall, entire thing will be supplied by the PDA, correct? So here when I go segment by segment, it is so clear that I already have a basal and mid inferior wall akinesia, okay? There is no thickening, this is moving. This is moving. But why it is moving? This is a translational motion. Okay, the translational motion occurs because the healthy segments pull and push it.
Pushing.
Okay, so there are two types of tethering motions. This is one tethering motion. So when the normal thing is pulling it and pushing it, it is called as a tethering motion. Okay, so this is akinetic. Though this is moving, I am calling it akinetic because this is not having systolic thickening. Because I know how is the systolic thickening. There is comparator there. So this movement is called as a tethering motion. Second thing is that there is another called as motion which is called as the translational motion. That means what happens is that this LV moves in and out of your imaging plane. Now suppose if you are in a long axis, either in a long axis in the central axis or you are in a short axis. If the image moves across the imaging plane, you know the LV is tapering on either side. Whether I go in short axis ahead, it is tapering. In long axis, if I go on either side, it is tapering. So if the heart moves through the imaging plane, you will have that feeling that the endocardium is coming closer. And you may feel that this is contracting, but it is not contracting. That is a translational motion. So tethering and translational motions are important to look at. And as I told you, now we know that this is area. Now look, go on the long axis view. Long axis view.
Apical long axis view.
Apical three chamber.
Apical long axis view.
Three chamber. Now here is the anterior septum and that entire thing is supplied by the LAD perforators. So the first septal perforator is here. So when this becomes akinetic, you know that is a pre-S1 stenosis, okay? When this is preserved and the rest is gone, this is a post-S1 LAD. Now here it is showing a systolic thickening. Again, one segment at a time, one segment at a time. I am not seeing endocardium here, so I am not going to comment. I know it is contracting here, and this is the posterior wall. Posterior wall is also called as inferolateral wall, okay? While our lateral wall is also called as anterolateral wall, okay? But it creates a lot of confusion, so we say lateral and posterior. Posterior wall is a watershed area which is supplied by either a very large PLV coming from the RCA or it can be even a distal OM. When you have just a PDA and no PLV, then the distal OM can also supply. So this can be either the basal and mid can be a supply of circumflex or can be a supply of RCA. Here you can see that it is thinned out, there is no, so again there is a motion here up and down, but this is a tethering motion, no systolic thickening. So this definitely is a PLV. So I know that this is a proximal RCA disease probably, or at least distal RCA, but PDA and PLV both are involved. And then the rest is okay.
But what is the basal posterior wall?
Posterior, I think that's the translational motion. Translational motion, because what is happening is this LV is coming in and out of the imaging plane. So it is picking up a part of probably a lateral wall. That is causing this thing, okay? Otherwise, it doesn't make any sense. How can you have PLV where the distal is infarct and proximal not infarcted, correct? Secondly, let us go for any regional wall motion abnormality has to be correlated in two orthogonal planes. So we'll now use a short axis plane in this basal, a short axis plane in the middle, and short axis in the hypocortical. So go on all the three short axes, and you have to confirm the motion in all the short axis views. When you confirm the regional wall motion in two orthogonal planes, then you commit for it. So basal, I know inferior is gone. Inferior is gone. Okay, a part of posterior. Now this is the insertion point, this is inferior, okay. This is lateral where the papillary muscle is. Here probably the basal, now just go back, just go back. We were seeing probably this. So here the basal posterior wall is preserved. So it could be that there is some large OM supplying there, correct? Now, so that is why I'm saying that you should be confirming any segment in two orthogonal planes. Come to the middle segment In the middle segment at the level of papillary muscle, yeah, it is still inferior and the posterior is still moving. So what must have happened is that your long axis view was off axis, correct? That was important thing. Now, on this view, okay, let us go to the apex. 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 Apex. Short axis apex. Short axis apex. Short axis apex. Extreme apex. Okay, so in short axis apex, I can see that except for the apical inferior, everything else is contracting. So this PDA is reaching an apex. So that is one thing. Now, you go back to a basal short axis view, and on that we will review the axis planes of the long axis. Okay, so when I am in 4-chamber, my axis runs through the basal inferior septum and the papillary muscle of the lateral wall. Okay, so this is the axis of my 4-chamber. When I am in 2-chamber, I run parallel to the septum, so my axis runs like this, anterior wall and inferior wall. Okay, and when I am in a long axis view, 3-chamber view, apical long axis view, keep that thing there. Na? Then my axis runs like this. So it runs through the basal anterior septum and the posterior wall. So that is the only way where I see the LED perforators, because here you have got a PDA perforators. So remember, this is the axis of apical long axis or 3-chamber view. This is the axis of 2-chamber view, and this is the axis of the 4-chamber view. 4-chamber view. Okay, so that is how it is. So look at the regional wall very carefully. Regional wall motion abnormality is the basic thing that is expected out of echocardiography, and it is much difficult to master. So that you lose all this. So always when I will see this, I will not look at the whole LV. I will go segment by segment, and then suddenly you start realizing the thickening, reduced thickening, and akinesia. Okay. So I see so many reports that there is a hypokinetic, scarred and hypokinetic. No, the moment you say something is hypokinetic, it is viable. Anything which is hypokinetic is viable.
Yeah.
So when you say akinetic, you commit that it may be either stunned or it may be non-viable. The moment you say hypokinetic, it is viable. Okay, and so that kinesis depends upon the thickening of that myocardium and not the motion. Motion can occur because of tethering and translation. So don't look at the motion. So that is and how do you appreciate thickening? You can appreciate only when you see the endocardium and epicardium. So that is why looking at the endocardium is so important. If I don't see endocardium here, I will not comment. Okay, I don't see endocardium here, then I will not comment. So you should see the epicardium and the endocardium. Now epicardium always looks very white because simple thing, pericardium has got a high reflectivity. So it looks white. Endocardium you have to pick up. So you have to adjust all your settings to get a good endocardium. Okay, and in 2 consecutive segments, if you don't see it, better to use a contrast. Okay?
So there was a small doubt from sir. He wanted to clarify about the inferior and the posterior segment. So what Nitin has been telling, I would just like to simplify. What generally we do is, in apical, we take the 4-chamber, 3-chamber and 2-chamber. The 4-chamber is the lateral and the septum, and everything is divided into base, mid, apex. The 3-chamber is anterior and inferior posterior. And in 2-chamber, it is anterior and posterior. But
anterior and inferior. Yeah.
And inferior. So, yeah. And always complement it with short axis views, which are to be taken at 3 levels, at the mitral valve, papillary muscle, and the apex. Yeah. Now, remember, if you are identifying a region of hypokinesia and akinesia in one segment, and it is not seen in the short axis, that means your imaging is a problem. It should go hand in hand. But there is a small caveat, Nitin, is that the apical images are only giving us subendocardial fibers. So that is a problem. And the short axis images are giving you all fibers, predominantly circumferential and subepicardial fibers. But to make it more easy, remember that in both the planes, they should go hand in hand.
Yeah, so the hypokinesia is obviously, especially stress echo, is much more seen better in the long axis than the short axis. Because short axis, the thickening is also because of the spiral fibers and epicardial fibers which push the endocardium down. But thickening is something which we are talking about. And as you know, at the basal short axis, take one short axis view, we have got the 6 segments at base, 6 segments at the mid. Apex, we have only 4 segments. So which 2 segments are not there in the apex? You don't have inferior septum there. Now just take a short axis, keep the short axis, keep the short axis, keep the short axis. So we have got anterior septum, inferior septum, then inferior wall, posterior wall, lateral wall, anterior wall. So you have got 6 segments. When you go to the apex, you don't have inferior septum and also you don't have posterior wall. For the simple reason, at the apex generally it is a type 3 LED supply. So the entire septum is called only septum, inferior wall is called only inferior wall, lateral wall and anterior wall. So you have got only 4 segments at the apex. And 17th segment is your apical cap.
Apical cap.
Cap. Okay, so that cap does not have any lumen in it. So that you would see only when you are using a contrast or on the MRI. So generally 16th segment is sufficient for the non-enhanced echocardiography. Okay.
Any questions?
Okay, I don't
But
know.
standard
not
is
aware.
16th segment.
17th segment
Yes,
is the standard.
See,
I
the
think
thing is
ASC gives you
16
17th
segment.
I mean,
Yeah,
we
see,
can
because
make
in strain, regional strains are not reliable. So we are going by the average longitudinal strain, which is robust.
That is the most
So
important.
we are not going by segmental. So what we are going for segmental is only the color pattern which
Pattern is-
qualitatively look on the bullseye, just to know the pathology. So
Pattern.
you are doing only qualitative assessment. So don't believe on the regional strain. The reproducibility is a matter of concern.
Pattern recognition is the only important thing you can do in the regional strain, I think.
And when
In
you
a
have got
certain
a
percentage
stationary
of cases.
object here, you can actually see that this is dyskinetic.
Yeah.
This is dyskinetic.
There was a part of aneurysm also.
Anything which is dyskinetic is non-viable. Okay, is non-viable definitely.
Number 11 is aneurysm.
It is highly echogenic, but I won't commit myself on
Should we
that.
call it an aneurysm?
Yeah, we can
Yeah,
say
there is an
aneurysm,
aneurysmal
yeah.
power, yeah.
But many times the echogenicity depend upon lot of technical factors. So,
now we are
will not
imaging
commit
it
on
as
This
that.
is the
harmonics.
aneurysm or not?
We are imaging
Yeah,
in
there is an
harmonics.
aneurysm.
So
This
because
is
if
an
I
aneurysm.
put it,
We should not
it,
comment.
it is, yeah.
So also we are imaging in harmonics, so whether we should comment, I don't know.
It is dyskinetic and aneurysmal, both.
It is, yeah.
Because dyskinetic could be without aneurysm or with aneurysm.
It is,
Dyskinetic, yes. And anything,
any mitral in MR in this patient?
yeah.
Because we start expecting MR or any clots. We didn't see any clot, but and also look at the RV function because so there is some central MR.
Let us look at this MR. You know what is the mechanism of MR?
Is it primary MR or secondary MR? Is there a mitral valve pathology? Do you
Yeah, that is very important. And
See,
another
if you look, is an inferior wall MI. This papillary muscle is displaced because of dyskinesia. You can see that the PML and the later part and the distal part of the AML are not coming to the level of the mitral annulus. So this is the annulus, and you have got a nice tenting of the leaflet there. So you know that this mechanism of MR is a secondary because of the papillary muscle getting pulled down. Okay. Now, if you look at this MR in short axis, you will find that this MR is coming from the medial commissure. Just go into the short axis and you will see. But this is a beautiful tenting, and the distorted mitral wall will be more in the medial commissure. So now put a color Doppler there. You have to see first the mitral wall orifice. Show me the mitral wall orifice. See, it's coming through the medial commissure. It's coming from the medial half. Medial half. Just go down, go down. No, just go to the mitral orifice. See, it's mainly coming from here. For the simple reason, this commissure is being supplied by the inferomedial papillary muscle, which is distorting the cavity.
even you can look at the papillary muscle also.
Yeah, so you can see that this secondary MR is coming from this particular. This I had expected just looking at the long axis because I knew the mechanism of MR. So this is pulled because of the infraposterior papillary muscle getting pulled. That is the mechanism. So always look for the mechanism of mitral regurgitation
Go to the
because
papillary muscle, please.
this has got a tremendous therapeutic potential, as you know, because in secondary MR in heart failure, you know.
Yeah, look at the papillary muscles.
It is
Put up
pulled
the color.
down.
Put up the color. Yeah. Look at the health of the papillary muscle here and health of the papillary muscle this.
Yeah, probably maybe fibrotic, but very difficult to comment that way. But what I was trying to tell you is that,
Yeah.
yeah, couple less, yeah.
Yeah. Volume is much less.
Correct, yeah.
Yeah.
It's possible, correct.
It's another important things. How much is the LV function in this patient? Do you think LV function?
Always do the biplane and
If you go to the papillary, the mitral orifice level, go back to mitral orifice level, and you will find that the MR is coming from this side. Yeah, at the orifice, and you will see the, and you saw that MR was coming from this side.
Yeah, Yaman is come from
Yeah,
the
you-
medial
yeah,
commissures.
yeah, it's perfectly seen there. So
From
you
the
know
medial
the
commissure.
cause, yeah. So if this is this if it has to be clipped, then you will, of course not this patient, then you will try to put the clip here. Yeah. Fine. So let us go for the next. This is the bicommissural view. Just show that bicommissural view. It is sometimes very useful because this is the view where this is the medial commissure, this is the lateral commissure. This is the lateral. So this is the P1 and this is the P3. And what comes and sits in between is the A2. So this is the lateral commissure, medial commissure, and the both chordaes should be seen, which are supplying the contralateral commissures. So this is a important one. Now if you put a color Doppler, you'll see that the MR is coming from this much more.
commissural
See,
view to
it's coming
see.
from the medial commissure, correct? It's coming from the medial commissure.
Post BMV, we open up this.
This.
Correct. Now, in this view, if you start tilting the probe anteriorly, you will see the AML and then the LVOT will open. Yeah, now the LVOT will open if you just tilt it anteriorly. Yeah, LVOT will open, correct? So you are going through the aortomitral curtain. So this bicommissural view comes somewhere between 4-chamber and 2-chamber. It will not be perfect 2-chamber. It will be somewhere in between. So this view is also important. Why this view is because, especially when you are looking at the myxomatous mitral wall, and sometimes if the P1 or P3 is a problem, you can see the prolapse there much better and the leak, okay?
Yeah. How much is the LV function? LV function in this patient? So while measuring this, well, they will measure it. You measure it.
Any questions till now?
Yeah. Now, you were talking about the lung ultrasound. That time we could not show them the what is the actual the A line and the B line. Now you can show them. So this is the, you can demonstrate them.
Yeah, that's the pleural line.
Yeah. Now can demonstrate that.
Yeah, so now this is a sector, this is the sector probe, I mean the convex probe, and what you can see that this black thing is actually the rib artifacts, the rib shadows, and you can see that these two things which are shimmering, okay, are actually the pleura which is moving on each other, okay, the shimmering thing, the white thing. Just go, you can stop that, can you stop that?
Oh,
See, you can see the shimmering line,
pleural
that is the
slide.
pleura which is sliding
Correct.
on each other, correct?
Yeah.
And then you see
These are the A
horizontal
lines. These are
okay,
the A
horizontal
lines.
lines, correct? So this is, they say, is like, looks
And now
like, say,
these A lines. Now we can take the better
these
A
are the
lines,
B lines.
in this way.
These are the A
And
lines.
so these are,
These A lines.
so
These A
what
lines,
happens is that
These
the
A lines, see.
ultrasound, just 1 minute, now the ultrasound cannot penetrate the air. So what it does is that, just keep
Just a
it,
minute.
just stop that, keep it there only.
Just a minute, just a minute.
Just go back, see, because that is very interesting. That
Yes, just a minute, just a minute. I'll stop it.
Yeah, so what happens is that, why it is not stopping?
I don't know.
Just freeze not the next one. This is this is actually the pleura,
This is the B line.
There is a pleural sliding. Basically.
pleural sliding. You go to that horizontal A lines. Yeah, and stop that, stop this, stop
It's
this.
not stopping. I don't know.
Yeah, so
Show
what
you
you
on
can
this
see
image.
showing this, what happens actually is that there is the ultrasound doesn't enter the air.
It's
So
not
what
stopping.
happens is the ultrasound wave go and come back from the pleura. And then they keep on doing ping pong between the surface of your probe and the pleura. So as it just keeps on reflecting either way, the second wave comes exactly twice the time of the first, third comes 4 times, 6 times that way. Each one the machine feels is coming from depth and depth because the depth is perceived by how much time the reflection is coming back. So you keep on seeing those white lines down. Okay, so that is just the reverberation coming
That is
from
actually
the
reverberation artifacts.
yeah. So
Now
that is
come the
the
B lines.
reverberation that you are going to get. Okay.
Now come the B lines.
Yeah, so what happens is that the ultrasound beam is just ping-ponging between these two. So the next things that which are coming are shown down, correct? And this shimmering line is the reflection. If there is no shimmering, that means there is a pleural fibrosis, correct? Now now the moment you have got fluid there, you will start bright white lines which look like fans going into the lung, and those are the comets, lung comets. Okay, those would be there in pulmonary edema and also in the bronchopneumonia also.
So presence
These
of
are B lines.
While if it is a COPD, patient is breathless, you will not see any line there. Okay, that is for sure.
Only A lines.
I mean, you are going to see those
Only lines,
horizontal
only
lines.
lines.
But you
You will
should
never
doc-
see vertical lines.
Yeah.
So unless the pathology is in the lung parenchyma, you will not see. So acute breathless patient, if it is because of a COPD or bronchitis, you will not see any comets. Okay, but if it is because of the pathology in the lung parenchyma, whether it is edema or bronchopneumonia, you will start getting those vertical lines. Yeah.
You should demonstrate 3 vertical lines in one zone.
Yeah.
That is
So that is why we go for the anterior ones, because then the pulmonary edema you will pick up more. Most of your pneumonias will be posterior and in the lower lobes, and they won't go. If there are all the places, I think that patient won't survive. But the thing is that you are getting the lines here, that means that is definitely pulmonary edema.
So this is the B lines you can take.
Yeah,
Yeah.
correct.
But you get much, you get something like this. You know, these ones.
Yeah,
Very
very
broad
bright.
comets, these broad comets. They're very classical. Actually, you start going into and doing it for all your LVF patients, and then you will know it, okay? And then you pleural effusions, everything you can see anyway, that is a different issue. How much time do we have?
We have we have 1:10. We have a 10-15 minutes time. No problem.
Yeah.
So I will tell you, sir. I can show. Can you just?
Generally, we do the same echo probe.
So let's do an. I will. So I will. She's doing an echo now. Let's do an echo. Let's do an echo regularly. Patient is in supine position, and this is the echo, right? Just see there, right? And once I put the same thing in the lung, now put the lung, right? So this, it is darker. So actually, no, don't. Just go back. Jaisa tha waisa rakha, right? So this is the lung line, which lung pleural sliding you are seeing at the top. I will show it with the pointer. There is a pointer. See, this is what I have to see. Okay, this is where I have to see. Okay, so what I will do is, I will decrease the depth and make it nearer. Okay, and I can also increase the width to have a bigger envelope. And now she is keeping it very still, and you see the pleural sliding. See, this is the pleura.
This one.
That is the pleural sliding. This is the pleural sliding. And these are all lines in the lung. See, this is all transverse lines. These are A lines, normal aerated lung. Use your echo probe very well. Once you change to other probe, your orientation may change.
And when you don't have this convex probe on your echo machine, na? And especially if you are carrying a V-scan with
Sorry,
you to
can
the
do with
patient.
any probe. Yeah,
Any
but
probe.
echo probe is also good enough.
See, when you are carrying the pocket ultrasound with you, generally you have got only echo probe. So, but you can see the, the comets, you can see it very well. Don't worry about that. You may not see this pleural sliding and anything. Now, there was a question asked, is the atrial fibrillation, RV pacing, LBVB, how do you know the diastolic dysfunction? So, let us start with atrial fibrillation. Now, let me tell you first important thing is that why does the atrial fibrillation occurs is because of the left atrial fibrosis. Why does the left atrial fibrosis occurs is definitely because of lot of comorbidities which are affecting the myocardium. So, the same interstitial fibrosis is going on in the heart muscle, LV muscles is also affecting the LA muscles. Now, LA has got only 2 layers of muscles. So, obviously it is going to be more obvious in the LA. All these comorbidities, hypertension, diabetes, OSA, obesity, all acting onto it to create atrial fibrillation. So by the time, atrial fibrillation itself is a marker of an advanced myocardial fibrosis and diastolic dysfunction. So let me put it that all the patients who develop atrial fibrillation, except for a very small variety, which is probably they call it as an LA cardiomyopathy, most of them with multiple comorbidities already have diastolic dysfunction. Okay. So that means the question is not whether it is a diastolic dysfunction or not. The question is whether the LV filling pressures are raised or not raised in atrial fibrillation. So we'll frame it like this: how to assess the LV filling pressures in atrial fibrillation. Otherwise, atrial fibrillation patient is already the heart is diseased. So there is definitely a diastolic dysfunction. Filling pressure. So first, very simple one we use, though in the literature there are a lot of these, I don't remember them, but I always remember 2 things. One is that just take a long mitral flow. If there is no variability in the E waves or very minimal variability, which is a very classic sign of filling pressures. Okay, because if there is a RR variability and you don't have any variability in the E wave, your LV filling pressures are very high or LA filling pressures are very high. Was it? If you have got a very nice E wave variability with RR variability, generally the filling pressures are lower. Second thing is you go by the E deceleration time, because that doesn't change. However, maybe the RR interval changes, E deceleration time generally doesn't change. Okay. Rest everything changes with this thing, and then the E by E prime, the problem comes is that if there's too much of variability, then what to take. So what people have suggested that you choose 3 RR intervals where the variability is less than 20 milliseconds and take that E wave.
Agreed.
And then take E by E prime. But instead of that, what I do is that just look at the E prime itself. If the E prime is less than 7, which is abnormal itself, isn't it? So I use only these 3, that no variability of E wave, E deceleration time very fast, less than 130, and your E prime is low. Okay, generally tells you that the filling pressures are high, because their LA volumes will be very big anyway because of atrial fibrillation, so you can't use that. If your E velocities are changing, then you don't know which one to take for E by E prime. So that's the problem. Anything more you can
what you were talking about, that's the most important, that in atrial fibrillation, you always look for that less than 10% variability. That means what you are talking about, if there is no variability, that means it's gone. That is the most important factor.
And obviously look at the second things like TR, velocity, pH, all those will also tell you that there is this thing. And on top of that, if you look lung ultrasound and see comets, you know that the LA filling pressures are high, wedge pressure is high.
Nitin, another important is that E by E prime ratio, even if it is more than 11, it's a very important prognostic. And Dr. O has been mentioning that in one of the lecture I was in co-presentator. Then you say this is one of the very important atrial fibrillation, E by E prime ratio, even if it is more than 11, that means LV filling pressure is more than 50.
So the question is only filling pressure, not diastolic dysfunction, because AF itself is a marker of diastolic dysfunction. Then comes the LBBB and the RV pacing. So RV pacing is like LBBB only. So it is an LBBB. You have created the RVBB. Now, LBBB patients also invariably have diastolic dysfunction. Why? Because as you have a dyssynchrony of contraction, you have a dyssynchrony of relaxation also. So some of the segments continue to relax in the early part of the diastole, and some of them have already finished their relaxation. So the so there is always a diastolic dysynchrony along with systolic dysynchrony in LBBB. So that means they always have diastolic dysfunction. Then again comes the question of whether they have got a filling pressure high or not. So here again the LA volumes will help you, E by E prime will help you, isovolumic relax. Now isovolumic relaxation time will always be prolonged in it because there is a slow relaxation.
Always.
So IVRT will not be useful. But the rest of the things, the three most important things, the LA volume, the E by E prime and TR velocity, they will not change just because of LBBB. If they are abnormal, definitely filling pressures are abnormal.
In this
But
patient,
as compared to diastolic dysfunction, they will always have because of the diastolic dysynchronous relaxation.
in this patient, you can see that in this our patient, there is hardly any variability even in this longitudinal.
No, but
So
this is sinus, but
No,
his
but
sinus.
I'm just we just wanted to show how to do it.
Yeah, but this
That
is sinus. We had that AFib earlier.
Yeah, this is sinus rhythm, I
This
think.
is sinus rhythm.
Another thing is that IVRTs, I think Dr. Nitin is
But
used.
actually, if you go back to our mitral stenosis AFib patient, he had a lot of variability in E waves.
Yeah.
And then also you saw on the ARPHT that the deceleration was very slow. So we already knew his LVD filling pressures are low. Okay, so that is how you can put the two things together. Okay.
No, Nitin, IVRT is only useful now in the recommendation is the if you have a mitral annular calcification.
Calcification, yeah.
That is the most important area where IVR has to be measured.
Measured, yeah,
because
because
whether it is more
isoval-
than 70 or less than 70.
Yeah,
You
why
can
do you
explain.
why do you require IVRT there in mitral annular calcification? Why don't go by E prime? Because E prime,
prime is
you should not be
calcified, yeah.
calculating when the annulus is calcified. Okay, so that is why you cannot get a correct E prime when the annulus is calcified for the simple reason because the motion is restricted because of calcification itself. So that is why if your measure, see, you have got only three dependable ones. Your E by E prime, your LA volume and the TR velocity. These are the most dependable ones. And isolated E prime also. These are the only four which are very important factors in that, for the filling pressures. So of that, that is already gone. Okay, when your calcification is there, you can't use E prime. Okay, then what remains with you, the isovolumic relaxation period, because that won't get affected because you are a calcification or not. But if you look at these patients with mitral annular calcification, again I know that they were going to have diastolic dysfunction because they are a subgroup of patients, unless they are not rheumatic. Any elderly patient getting a mitral annular calcification or structural calcification generally have multiple comorbidities. And rather that itself is a sign of the patient going into HEPPEPs. Okay, most of this will have hypertrophy, calcification of the annulus and multiple comorbidities. So that annular calcification itself tells you that this patient is having this patient has got he is actually going in the direction of HEPPEPs or probably AFibs also. They will have the larger LAs and everything.
We have 10 minutes times more. And my dear colleagues, if you have any questions regarding anything about echocardiography, any doubts, we have two excellent experts from the India, one from Nagpur, Dr. Santanu Sengupta, and one from Dr. Nitin Bonkule from Mumbai. You can ask any question for the free question session in the next 10 minutes.
If you don't ask, we'll ask you.
That have already been discussed. You were not there.
Yeah, I'm just.
I will just
So I think
add,
you'll repeat the.
I will
EMS.
just
Yeah,
add,
yeah.
once you see the morphology of the aortic valve, the best is to do for dimensionless index. It is looking at the PW at LVOT and then PW at the aortic valve. So normally, if it is the ratio of LVOT VTI divided by the aortic valve VTI, if it goes below 0.4, we start becoming very careful. If it is less than 0.3 or 0.25, you are dealing with aortic stenosis. And then we can always go for the aortic valve area by the continuity equation, by looking at the stroke volume divided by the LVOT VTI. That's the formula.
First of all, you should know that patient, okay? You can't just do like a technician, that is most important. And try to find explanation for each one of them. And then suddenly you get a tremendous insight into the management of that patient. So explain everything. So look at the 2D very thoroughly and try to explain everything, okay? And then you will land up with the, your answers. So just don't blindly take 3 views, then take the flows and everything. Don't do that way. Try to look at why the LV looks bigger, why the LA looks bigger, okay, how is the mitral wall, whether they are co-opting well or not, or it is tenting, okay, how is the aortic wall pathology, how is the annulus and calcification, because you know that most of these patients with comorbidities, they develop annular calcification, aortomitral calcification, so whether they are developing this calcification or not. How the LA, what are the LA volumes, whether indexed to the body surface area, they are already high, you already know that the filling pressures has to be high in absence of a significant MR, so and so forth. So just go one step at a time.
One minute.
Yeah.
Dr. Nitin, regarding giving the report for effective orifice area and prosthetic valve calculation. Prosthetic valve, mitral, suppose mitral prosthetic, and exactly calculating the area of EFO. What practicing you in day to day?
Yeah, so the EOA, yeah, the effective orifice area. So generally what you tend to do is that for that particular patient, first of all, you should have multiple, yeah, different, yeah. So what you do is that you always refer to the reference table. You know the valve, whether it is in aortic position, mitral position, what make of the valve and what is the size of that valve. So that is information you have to have, otherwise you don't can get. If you go to that reference table, you will know that that particular valve's EOA, the manufacturer's EOA, okay, and you also know the manufacturer's, the manufacturer given the gradients, Doppler gradients on the normally working. Then you do your echo, okay, before even touching the patient, look at the EOA of say a 21 millimeter valve put in a aortic position, say St. Jude, and that guy is 2 meters square. Then if I look at the 21 millimeter, if its effective orifice area itself is 1.4 square centimeters. No, I'll tell you, before even doing the echo, if it is something like say 1.4 square centimeter, and he's a 2 meter square large man, I know that already there is a ppm, because 1.4 divided 2 is already 0.7. So I know that there is a ppm I am going to expect. So that means before even touching the patient, you divide the manufacturer's EOA by the patient's body surface area and think whether he is going to have a ppm or no ppm, correct? Then when you do it, then obviously you should have the mitral VTI, aortic VTI, LVOT dimensions, and from that you can get the mitral wall EO effective orifice, or if it is a aortic, then you take LVOT and aortic VTI and get the EOA for the aortic wall. Put those EOAs, peak gradients, mean gradients, against the manufacturer's one, and look at what they were before discharge. So the whole thing is about the linearity of measurements over the years, okay, over the years is very important. So you know that the gradients were high, EOA was small, the ppm was there even at discharge, the same thing has remained now. Or you say there is a drastic reduction in the EOA, gradients have gone up, that means he is developing a PANUS or something, or sometimes you find that the EOA has not changed, but the gradients have changed in the mitral situation, very rapid E deceleration time, you know that you are looking at a paravalvular leak. Something like that. So the DVI is very important in prosthetic valve, and then calculating the EOAs and the gradients and comparing them with the previous one and always normalizing them to body surface area are the essential things. That saying that one, let me also come back that the timings of the Dopplers are very important in prosthetic valve. So in the aortic position, look at the ejection time and the acceleration time and the ejection time and their ratio, very important, because if it goes above 100, the acceleration time itself, you know that there is an obstruction, okay, nothing else, because even if it is a hyperdynamic or even if it is a milder variety of ppms, generally the acceleration times won't go so high, 100, okay, so you know that either it is a very severe ppm or it is already developing PANUS or clot or whatever. So that is one thing. And the mitral side, look at the E deceleration time. Though gradients are high, but E deceleration time is fast. That means you are missing a paravalvular leak. Then you search for that paravalvular leak on a T or something. So also you look at the E deceleration time looks like as if it's a mitral stenosis. Then you know that he has a stenosis. Then look at the DVI for the mitral wall, and if it goes about 2.5, you know that definitely this effective area is as low as 1 probably. Okay, and that is because we said now when it is already 2, that means it is already halved of the LVOT area. So it is already 1.5. So it is 2.5, that means it is already gone nearer to the 1. So that is how, that is 1/3 ho gaya. So that is how it is. So all these things, so even looking at the Dopplers carefully is very important.
I believe this has been an extremely engaging session
I
for
think-
all of you, and it
yeah.
is time that we break for lunch.
1 second. So I think before that, we should give a round of applause to the performers. The echo performing was very good by Dr.
Yeah.
Kaustu Biswas
He
and
calls for a great
Dr.
round of
Banerjee.
applause.
And of course, our expert, Anuruddha Dik. You were amazing. He covered everything, I think, today. A lot of echo has been covered.
So thank you, mentors. Thank you, experts.
Thank you, everybody.
And it is time that we break for lunch, and we will be back sharp at 1:40 to begin with the next session. Till then, you can take the discussion forward over a good plate of food. Enjoy your lunch, and we will be back here right at 1:40. Thank you.